Good afternoon, and thank you everybody for attending this session of Advanced Lung Failure and Transplantation of the George P. Noon Conference Series. I'm Dr. Osama Gaber. I'm the founding director of the Houston Methodist J.C. Walter Transplant Center, and I'm pleased that you could join us in this year. This advanced lung session has actually the largest number of attendees. That's the power of virtual for you. We almost have 300 attendees that have signed up for the conference, and I suspect the majority of them are logged on at this time. So it's amazing to have you all. What I usually do in these situations is introduce the Methodist Hospital and the Transplant Center to all of our attendees that are not part of our program, because I think it helps everybody to understand a little bit of where we've come from, where we're going, to understand the context in which this educational activity is being introduced. The Houston Methodist J.C. Walter Jr. Transplant Center is one of the 5 centers of excellence at the Houston Methodist Hospital. Our largest partner is this one here, the Houston Methodist DeBakey Heart and Vascular Center, where we've worked together for the past, God knows however many years since both centers were started, to create this very vibrant cardiothoracic transplant program and left ventricular assist device program. And we think that this has been a tremendous partnership, because today the J.C. Walter Jr. Transplant Center not only does solid organ transplants like lung transplantation, heart transplants, of course liver, kidney, but we also are a very large center for advanced organ failure management. We have special interest in amyloidosis, bone marrow transplantation in collaboration with our colleagues from oncology. We do allotransplants, vascularized organ grafts. We did a skull and scalp transplant and an abdominal wall transfer transplant, and of course a lot of ventricular assist devices. This year also, we've had a new director for the Transplant Center. I think when I started in 2006 as the director, it was time now to pass it on to Dr. Mark Gobriel, who has been the director of the Liver Center and now has taken on the whole Transplant Center, and I hope will take us into new directions and places that we weren't able to go before. So the Houston Methodist Transplant Center has a very long history. It goes back to 1968 when Dr. DeBakey did one of the world's first 12 heart transplants. And in that same year, he did our first multi-organ donor. And instead of reading you all of these firsts that we did here, I want to show you this picture of the lung transplant that was done in 1968. This is an AP photo by the Methodist Hospital, and it says that William J. Whaley, 39 of Florida, received a lung transplant from a donor that suffered from a gunshot wound. 3 other organs taken from the same donor were transplanted at Houston Methodist, included a heart and 2 kidneys. And this really ushered the world of multi-organ donation and transplantation, and we're so proud that it happened here at Methodist. And Dr. DeBakey, in the subsequent press conference, was sitting beside Dr. Joe Morris, who did the 2 kidney transplants, and Dr. A.C. Beal, who did the first lung transplant here at Methodist. So we come a long way from transplantation 1968 till today, but we stand on the shoulders of these giants that really kick-started our program. Dr. George Noon, this handsome young man here, couldn't be with us this year, but Dr. DeBakey and him worked closely since probably the early 70s together to start and to advance the transplantation program here at Methodist. And in recognition of his contribution, the conference has been called in his name. Dr. Noon traveled the world spreading the innovation of the Methodist Transplant Center, and this is him in Moscow with a Russian physician. He was showing him the Noon DeBakey left ventricular assist device that Dr. Noon and Dr. DeBakey had put together by going to the engineers at NASA and asking them to help solve the problem of left-sided heart failure. And this is Dr. Noon putting that left ventricular assist device and the Russian physician observing. Clearly they are working on an animal because they don't have masks on, but this is a way for us to transfer technology and advance it. The Methodist Transplant Center, when we started the J.C. Walter Junior Transplant Center somewhere around here, had been in existence for a long period of time. It's been growing on a steady pace and it had excellent results. But we were able, through the leadership that we recruited, the surgeons and the team, to really promote the amazing growth that you see in the Transplant Center to where today we are projected this year, the COVID year, with all the interruptions in work and social distancing and so forth, to do project almost 614 transplants. And we are the largest in the region, both Oklahoma and Texas. This past year, at 525, we were number 13 in the country. We don't know when we get to 560 where we're going to be, but hopefully it will be in the top 10 centers in the country. We do what we do through a huge amount of end organ failure work that includes 5,000 referrals, 2,000 people that we work up for a transplant list, and almost 1,000 people that we list every year. And this concept really has helped us develop this amazing center. But what has been really exciting is in the last maybe 10 years or so is our renewed emphasis on research, basically reverse organ failure and rejuvenation, research in transplantation surgery, and then organ restoration. And I'm sure Dr. Wong is going to talk to you about a lot of this. He's been leading an important part of it. But I'm going to show you that today, as when I stand here, there are 56 trials that the Transplant Center is doing, 20 in kidney, 20 in liver, but lung transplantation is 11 trials. A lot of them are ascribed to Dr. Wong. And a lot of them are in COVID patients, which I'm sure is going to come up in the discussion throughout the day. We just recruited a new researcher, Dr. Joan Nichols. She is going to bring us some new technology in bioengineering of lungs. Dr. Nichols has spent her time trying to create new lungs from old lungs that you find. This is a pig lung that has been decellularized. So she takes all the cells off of the lung, and then over time, she puts back the cellular elements into the cytoskeleton of the lung. And as a result of that, you can see a new pair of lungs developing that she actually did transplant into pigs. And 2 months after transplantation, you can see one of the lungs didn't develop, but the lung actually looks quite well and is working. And I think together with Dr. Wong and the transplant team, we hopefully going to be looking at advancing that work into human lungs and creating a bioengineered lung for transplantation. We also, to support this work, we have a whole lot of transplant philanthropy. And just in the past 7 or 8 years, we've raised almost $23 million to support our research. And we look forward to finishing our first campaign goal of $25 million over the next year. Finally, our greatest source of pride has been the stories of our patients and how they do after transplantation, and the new innovations that we have in every organ that allow us to help our patients. That's one of the reasons why we were able to work through the COVID pandemic. Our team is strong. It's led by Dr. Howard Wong. It has Dr. George Youssef, Dr. Ahmed Goodarzi, and Dr. Simon Yao. They're very active in research, 11 trials. Both Dr. Youssef and Dr. Wong are the PIs on quite a bit of them. And I think our whole team participates in that. And I think Dr. Wong has been a tremendous asset to the whole institution in terms of dealing with this COVID crisis. Our surgeons are also very active with the program. They are the ones that make it possible to put all of these lungs and have these amazing results. Dr. Tom McGilvery, Dr. Eddie Suarez, Ed Chan, and Ray Shahara have been really amazing group of surgeons to work with their understanding of the concept of surgery and with their support of our efforts. And as you can see, I think Dr. Wong will talk to you, but to be able to do or to project over 65 transplants in the middle of a COVID pandemic with as excellent results as he has is really an amazing feat that I think we should all really be in awe of, because it's really difficult to do. But through their patient education, through all the protocols they have put together, they've been able to safely transplant those lung patients, save their lives, while also saving them and keeping them away from infection. I'm going to stop here and give the microphone to Dr. Wong to take it over from this point and introduce the speakers and do the conference.
Okay, well, thank you very much for joining us today. I'm really privileged to present this conference that's named in honor of Dr. Noon, true pioneer in cardiothoracic surgery. And I think this year's symposium, I hope you will find to be very informative and also very kind of high intensity, if you will. So it's a short series of talks, but I think it's very dense in terms of the information that you'll learn. And one of the things we like to highlight is the fact that, you know, transplant is a great option for certain patients, but candidate selection is key. And unfortunately, we can't offer transplant as an option to every patient. But one of the things that we try to do is kind of think a little bit more broadly and look at lung disease as a whole. So advanced lung disease and lung failure and kind of this continuum of disease progression. You know, so even within the context of transplant, that the earlier somebody receives the appropriate interventions, perhaps the better candidate they become for a transplant down the road. You know, so we know what's expected. We have a management plan going in, and so the focus of today's symposium is really to think kind of broadly about interstitial lung diseases in general. And so we put together an excellent group of speakers, and I want to thank them for contributing their time and effort and sharing their knowledge with us. And I hope at the end of this symposium you'll have much greater insight into kind of the current topics relevant to interstitial lung disease and how it relates to lung transplant. So our first speaker will be Dr. Joe Lasky. So Dr. Lasky is a professor of medicine at Tulane University. He's been there since 1993, and he holds a number of leadership roles. So he's a very well-known investigator in the field, has published very broadly in lung disease in general. And he's a recognized expert in interstitial lung disease and has headed up multiple clinical studies funded by federal agencies and also by private foundations. He did his medical training at the University of Minnesota and his residency in Mayo Rochester. Then he completed his fellowship training at Duke before joining the Tulane faculty. So today he's going to talk to us about the current developments in interstitial lung disease in terms of therapies and kind of what's coming down the road.
Hello, everyone. Good afternoon. My name is Joe Lasky. I'm a professor of medicine at Tulane University. I head up the Interstitial Lung Disease program there. I want to thank the organizers of the Houston Methodist J.C. Walter Jr. Educational Series on regarding this advanced lung disease and transplantation. So the title of my talk today is The Cutting Edge or Fuzzy Border of ILD Diagnosis and Management. There are numerous disclosures to be made here. I won't spend too much time on this slide. Suffice it to say that there are many, and they are listed in the pamphlet that you get. I think the most important disclosure is that I've been described as a rabid fan of Tottenham Hotspur, shown in the lower right-hand corner. So I'd like to give an overview of this talk in 3 questions, and that is, what does a patient want to know when they come to our office? Number 1 is, what do I have? They want us to give this a name, and that's the diagnosis part of this presentation. And there's power in knowing something's name. So if we're able to classify it as something, well, we get a little dopamine surge, and that feels good for us. Number 2, they want to know, is this bad? Am I going to be all right? They oftentimes say, well, at least it's not cancer. We'll talk more about that later. But here, it's the power to predict the future. And to quote Yogi Berra, it's tough to make predictions, especially about the future. And number 3 is, can you fix this? And we're going to get to the treatment aspect of the talk. But that's really the thing where we're going to exert the most influence for our patients if we can change the future by providing some therapy. So it's a tough task because there's 150 different causes, maybe more, of interstitial lung disease. And the symptoms are not very specific. It's cough and shortness of breath. And there's a whole lot of other diseases that are much more common that cause shortness of breath and cough, namely COPD and congestive heart failure. There's tens of millions of patients with those entities. But with ILD, it's in the range of the hundreds of thousands. Because of this, there's often a delay in making the diagnosis. And with this delay, in the absence of treatment, there's a loss of lung function that we regret. Now, fortunately, the majority of these causes of idiopathic pulmonary fibrosis can be, or pulmonary fibrosis can be classified into occupational, side effects from medications, autoimmune, sarcoidosis, or idiopathic. So this is a study based out of PFF registry, their work with that foundation. It's published by Greg Cosgrove and all. And here it shows that more than half the patients are initially misdiagnosed, 55%. And some have 2 misdiagnoses or more. And what are they misdiagnosed as? It's shown over to the right. Asthma, pneumonia, COPD, obesity. They've gotten flabby, various different things. And so here it shows from that same manuscript that there's a delay in the diagnosis. And maybe 30% of patients, that delay is over 2 years. And again, precious time is lost in treating this patient as they lose lung function with this delay in diagnosis. And the sad thing is that a lot of lung function is lost before a patient ever becomes symptomatic, particularly if they're elderly. We can take a beating, lose a lot of lung function before we start to become symptomatic with our activities of daily living. So to help pare this down and get the differential diagnosis down to one thing, you can just remember this simple mnemonic, Mayo Nid Pesci, miscellaneous, ARDS, occupational, and so forth there. Of course, these mnemonics are a gift from Nemesini. She's a Titaness. And via Zeus, she gave us the muses, which we're all glad to have. I'd like to bring up this slide for the house staff, and the younger practicing physicians. And prior to 30 years ago, mnemonics is what we relied on. Now we've got Wiki and Google and the internet and all kinds of things. So slowly this is slipping by the wayside. Another way to look at this would be, classifying interstitial lung diseases into this big ball, and in that ball is hypersensitivity pneumonitis, connective tissue diseases, drug toxicity, occupational pneumoconiosis, and some other rare diseases. Then within that, you've got these idiopathic interstitial pneumonias, and then within that, the one we focused on for the last decade is idiopathic pulmonary fibrosis. And one of the reasons for that is a third of these interstitial lung diseases will turn out to be idiopathic pulmonary fibrosis. So there's good reason why there's been focus on that. It's a devastating disease. Well, we have to make the diagnosis in order to prognosticate and get to that second question. And so we're looking at the prognostic significance based upon the etiology. In this case, etiology and the pathology. We're looking at a slide showing mortality over time. And the highest slide, indicated by the red, the highest line there, is for idiopathic pulmonary fibrosis. That's the worst actor. But even patients with chronic hypersensitivity pneumonitis, on average over time, have a high mortality. And then somewhere in between is connective tissue disease, which oftentimes has a nonspecific interstitial pneumonitis pattern. So, getting the diagnosis right will help us with question number 2. What's the future going to be? What can I expect? Now, if it's idiopathic pulmonary fibrosis, this is some older data, but survival is worse than many cancers and almost as bad as lung cancer. So we've got 5-year survival here, percent, and then we have these various maladies, and you can see that IPF is not a good diagnosis to have. So the patient's relieved when we tell them that they don't have cancer, but then when we tell them that this is a bad disease, then that relief goes away in short order, unfortunately. Another issue I'd like to elaborate here on is that many of these fibrotic lung diseases, including IPF, the cause of death is the pulmonary fibrosis. So they die from the pulmonary fibrosis. And this is showing here that maybe 2/3 of patients would die of the fibrotic lung disease. So we've got some help here from guidelines, most recent published in 2018 in the Blue Journal. We suspect the patient may have an interstitial lung disease and take a thorough history and do a thorough exam, and we might come up with something, cause for it. And if that case is the case, we find that the patient's got rheumatoid arthritis and has pulmonary fibrosis, we have the cause, and we don't need to do much further in that regard. Very key in the workup, though, is the high-resolution CAT scan and looking at those patterns. And our thoughts about those patterns has been changing over time, as influenced by the radiology societies. So we take the history, do the physical, get the high-resolution CAT scan, and then go to this thing called an MDD, a multidisciplinary discussion. And we're going to talk a lot about that during this presentation. And then they may be able to make a diagnosis, or they may say, no, we need more information. We need some sort of a lung biopsy. And at the time that this was put together, it was a surgical lung biopsy that was recommended. Oftentimes a video-assisted thoracoscopic surgical biopsy. And then the MDD would meet again with the help of the pathologist and then be able to make a specific diagnosis. So what about this MDD? And this is a very nice paper by Chris Ryerson, published in Respirology just recently. And what is this MDD? Who, what, and how? And we've got the patient in the center of it, of course. We've got the ILD clinician, nurse educator, other professionals in the health fields, including pathologists, rheumatologists, radiologists, and then maybe thoracic surgeons, unfortunately palliative care, lung transplant as well, and then of course staying in touch with the general practitioner. And we have these roles here for the ILD clinician and the nurse educator. I think the nurse educator is just as important as ILD clinician in working up these patients and treating these patients. But we'll talk more about those roles as we move forward. So what does a referral to a place that has a multidisciplinary discussion do? And this is one paper published about 4 years ago in Respirology. And there was a change in the diagnosis in 53% of these 90 patients that were referred. So it does make a difference in regard to specific diagnosis in many cases. And 27 of these patients that were referred with the diagnosis of IPF, again, which is a bad diagnosis, a third of the time of those, the diagnosis was changed to something other than IPF. And that other thing, tends to be connective tissue disease or hypersensitivity pneumonitis. But in some cases, the diagnosis was changed to IPF in 7 of the 90 patients here. So sending to a multidisciplinary discussion group or the ivory towers at times can change the diagnosis and then thereby perhaps how we treat the patient. Do all patients need to be referred for an MDD? And some insight of this is derived from some work that Kevin Flaherty's done looking at the Pulmonary Fibrosis Foundation's care network, Centers of Excellence. And he reckons that about 42% of patients that were referred for the registry wound up going to an MDD, which means that more than half did not. And of course, these are centers that are supposed to promise that they're going to use an MDD. So in a real world situation, maybe not one of these care centers, I suspect it's much less. But here I'm showing a picture of Dora Maar, and it doesn't take an art historian to know that this was painted by Picasso. And so I'd like to draw this analogy that not every patient needs to go to an MDD. And so I'll give some illustrations of this on this next slide here, where we're looking at the panel to the left. Let's say we've got this upper zone predominant disease with reticulation and ground glass and bronchiectasis, and the patient has some rales, but they also have some pops and squeaks in the upper zones, and they happen to have a African gray parrot named Bingo. And so, the odds are pretty good that this is going to be a hypersensitivity pneumonitis. Let's look at the middle panel. The middle panel has a CAT scan that more often than not, if you did a biopsy, is going to show a nonspecific interstitial pneumonitis. So let's put this together with a woman in her 40s who has Raynaud's and sclerodactyly. And so here we could pretty much have a high index of suspicion that this is NSIP associated with somebody who has scleroderma. And over to the right, we have a CAT scan of somebody who's got a lot of central changes. We're in the mid-lung zone here. Not shown here is that there's some lymphadenopathy. It's a 27-year-old African-American woman. In New Orleans, more often than not, this is sarcoidosis. So, so these are some cases that, probably don't need to go to a multidisciplinary discussion, at least for diagnostic purposes. Maybe they would go there if you were trying to sort out how you were going to the patient. So moving on then, what's the role of the clinician then in this multidisciplinary discussion? And it's to take the history. Is this something that's been going on for 2 months or been going on for 3 years? Looking at the medications that the patient's gone, whether they've had radiation to the chest, taking environmental and hobby, environmental occupational exposures here as well. Doing an evaluation for symptoms of connective tissue diseases. Are they very stiff in the morning when they're getting out of bed? Their hands are stiff. And doing an examination in this regard. Of course, we still listen to the chest. Are we hearing those rales in the lung bases? Rale is a French word for rattle. I don't think we use the word very much anymore because of the death rattle. I suppose that patients wouldn't want to hear that they had the rattle. So now we use crackles and things like that. But we can also listen for other sounds like pops and squeaks in the upper zones, which would suggest maybe this is a process that's involving the airways as well, which we might see in patients who have a hypersensitivity pneumonitis. Of course, we're going to order and interpret those pulmonary function tests. And then, very key, we have to order the appropriate high-resolution CAT scan of the chest. And so we have to pay attention to what we're ordering in that regard. And here's just some examples of, sclerodactyly. I've had many instances of patients that were referred for a treatment of IPF, and you shake their hand and it feels like this, and you're dealing with an autoimmune disease. Or these mechanics hands you might see on occasion in somebody who's got dermatomyositis, or may have antisynthetase syndrome. And of course, we have to take a drug history as well. The common and boardable drugs are listed here, but new ones are coming along all the time. Now with the checkpoint inhibitors, we're seeing a significant amount of interstitial lung disease associated with the use of these drugs. There's just a whole slew of drugs that have been linked, at least in case reports or small series, and I tend to use the Pneumotox website that was developed by Philippe Camus in Dijon, France, and so that's why I have that on here. But definitely have to take that history, drug history, more than once, because oftentimes the patient forgets to mention certain things the first go around on the first visit. So in regard to ordering that high resolution CAT scan, what do we want to do to ensure optimal imaging? So we want this high spatial frequency reconstruction algorithm. We want the thin slices, maybe 1.5 millimeters. We want to maximize how much on the image here is lung and get away from the soft tissues in the imaging. This is a non-contrast scan, so contrast is not needed. We want to make sure, especially with patients with subtle disease, that we include supine and prone positioning, because sometimes some atelectasis, particularly in people that are obese, can show up posteriorly in patients that are supine, and you flip them over and it goes away. So it's good to get those prone positioning. And also you want to include expiratory imaging as well as inspiratory imaging, specifically in looking for air trapping. So just to remind you that chest x-rays may appear normal in maybe 5 to 10% of patients with interstitial lung diseases. One that's maybe seen more commonly than other in this scenario would be a hypersensitivity pneumonitis, which is shown on the CAT scan below. Same patient, same x-ray, same CAT scan. So the Fleishner Society has weighed in recently, that's our radiology society, on reclassifying how we interpret these CAT scans of the chest. And so here's an example on the left of something that is a definitive CAT scan for a patient who has usual interstitial pneumonia on the pathology. And so what can we see here? It's reticulation, it's peripheral, it's lower zone predominant, and the arrows are pointing out that there's honeycombing. And in addition to honeycombing, there's bronchiectasis there. So it has all these features, and when you see that all together, you can pretty much bet that if you did a biopsy, which you don't recommend under these circumstances, that you're going to see usual interstitial pneumonitis. From that, we have a CAT scan that is probable for usual interstitial pneumonitis. And so what's different about this CAT scan? Well, it's missing the honeycombing. And so we're getting some views here where we have a coronal and constructions, and we could even look at sagittal constructions. And that's helpful for differentiating, what is bronchiectasis and what is honeycombing. And so in this case, we've got a lot of what we had in the prior CAT scan, but we don't have the honeycombing. Got a little bit of ground glass in panel C there too, maybe a little bit more than we're comfortable with. So we're going to call this as probable. And in the right scenario, and the right scenario is a guy who's older than 65 and smoked, nothing else in the history or examination to make you feel otherwise. Odds are also that this is going to be usual interstitial pneumonia as well. So it's all regarding the context of the patient in regard to these probable. And then we go to the scans that are possible. or maybe indeterminate. So these tend to be more mild disease. They might have got picked up just because a patient had a cough from their flu, and then somebody heard some crackles, and then they wound up getting this CAT scan, or maybe this was some lung cancer screening that was done, and something abnormal was noted, and so we moved on to the high resolution CAT scan. And so what is this missing in comparison to the prior two slides? And there isn't much in the way here of bronchiectasis, and there isn't much in the way here, there isn't any honeycombing. And so this goes into something that's indeterminate. And then have something where you have a CAT scan where we're saying, well, we probably got an alternate diagnosis here. And so, what are we seeing here? The upper zones are at least as involved as the lower zones. The central regions are almost as involved as the peripheral regions. Yes, there's bronchiectasis. No, we don't see any honeycombing in this situation. And then in panel B, we see this inhomogeneity, and it's accentuated in panel C where you have the expiratory film. So we have air trapping in this, and so this would be pretty classic for somebody who had a hypersensitivity pneumonitis. And that we'd expect to see that on the biopsy rather than usual interstitial pneumonia. Here's where it gets a little bit tricky, though, and that is, do all of these multidisciplinary discussion panels agree with each other? And so somebody actually did a study on this, and they looked at 70 patients, 7 different multidisciplinary discussion groups, and the overall kappa for the first diagnosis was 0.5, which is okay to good, but there's certainly some disagreement. They agreed a little bit more with IPF. I think it was very good for that, but for some of these other entities, it wasn't as good. And so here we get into the issue of accuracy, precision. We want to be accurate and precise. I suspect that some of these MDDs have been working together as a cell for a period of time, and they kind of gravitate towards agreements. And one MDD, clearly doesn't always agree with another one, as they're influenced by the members over time. So that's a little bit of uncertainty between the MDDs. So let's move on to why that might be. So let's look at this picture here. This was first described by Joseph Janstrow in 1899 in the Fliegende Blätter. And what do we see here? What do you see? Well, some people see a duck and other people see a rabbit. And, we're looking at the same image, but we're seeing different things. And, interestingly, even by the time of the year, this could change in a population as to what you see. In the spring, people tend to see the rabbit. In the fall, they a little bit more tip toward the duck. Another example would be this picture here. It's of Margaret Thatcher. She led the conservative group in the United Kingdom for a very long time. And we looked at the panel on the left, and she's upside down there, but it's clear that this is Margaret Thatcher. Well, over to the right, it's the exact same picture. Nothing has been changed. It's just been flipped in a different direction, and she looks like a monster in this, and I'm sure this is how the Labour Party saw her. So again, this is part of being human, and what our eyes do to us. And then my last illustration is this Adelson effect. And so the question here is, which square is darker, square A or square B? Well, it's, to my eyes, it's obvious that A is darker, but in reality, they're both the same shade. And so the illusion of the cylinder, which is shading this, is making us think that B is lighter. And so I point this out because when I go down and talk to radiology, I usually wind up first talking to one of the radiology residents, and they show up and they're sitting in their nice comfortable chair and they lean back, and the first thing they say, well, tell me about the patient. And I say, no, interpret the film. Tell me what you see in the film. I don't want to shade your interpretation by telling you about the patient. So this is really hot off the press, and this is work by Steve Nathan in the Nova Fairfax hospitals. So he's looking at the same cases here, and he's kind of made a little heat map of the interpretation. And so to the left, we've got the 2011 guidelines, and we've got the 2018 guidelines to the right. And so we're classifying whether the individual reads that CAT scan as definitive for UIP, possible for UIP, or inconsistent on the left, and on the right we've got definitive, probable, indeterminate, and an alternative diagnosis. And most of these were pulmonologists. One of them was a radiologist, but some of these cases, I think two of them here over on the right, you get interpretations of all four of these by different interpreters. And so I think this could lead to some variance in what an MDD would say based upon what the person interpreting the CAT scan is showing. So let's talk a little bit about pathology in regard to guidelines. And so we're going to divide things. To the right, we have these CAT scans, which are definitive. And to the left, we've got all the other CAT scans, the probable, the indeterminate, and the alternative diagnosis. So let's go to the right first, because that's a little bit easier. So what do they suggest? Not. No BAL, no surgical lung biopsy, no transbronchial biopsy, no transbronchial cryobiopsy. So these are so likely to be usual interstitial pneumonia, there's no point in getting a biopsy. You're just exposing the patient to morbidity and mortality. Whereas, how about all the other ones? Well, for BAL, they're suggesting, there's that word suggest, performing first cellular analysis, and this is conditional. And I think this was highly influenced by the practices in Europe. Surgical lung biopsy was suggested, although it is conditional in this regard. Some patients are feeble and just can't tolerate a surgical lung biopsy. And then, of course, this was published in 2018, and so it was talked about in 2017. And so there's a lot of data that's come out since on transbronchial biopsies and cryobiopsies, and we're going to go over that in some of these next slides. But, to illustrate here what we're looking at in regard to what the pathologist gets to look at, on the left we've got the papa bear, and the right we've got the baby bear, and what I like to consider, and this is my bias, these cryobiopsies, the mama bear. To me, it's the one that's just right. But again, that's my bias. That's not what guidelines are saying at this time. So why do we need to get these biopsies? And one thing is that 60% of patients who have usual interstitial pneumonitis, they don't have that definitive CAT scan. And so in order to make an accurate diagnosis, we have to do something a little bit more. The concern is with these surgical lung biopsies is the mortality that may be associated with it. It could be up to in the range of 3%. It tends to be a little lower in those that you're doing as an outpatient than those that you wind up doing in the hospital. But just as with the interpretation of the CAT scans, the interpretation by the pathologist also has some variability associated with it. And certainly we have some patients that just aren't willing to undergo this surgical lung biopsy. So we might need to have other options, particularly for those patients. And so here's a study by Nicholson looking at these weighted kappa coefficients on agreement on these surgical lung biopsies. For UIP, it was pretty good. NSIP, not so good. Organizing pneumonia, pretty good. Hypersensitivity pneumonitis, meh. Sarcoidosis, really good. So, the interpretation by these experts is moderate, good in some instances, but it's certainly not perfect. And so, that's going to lead to some variability in regard to the final outcome from the multidisciplinary discussion. So let's make some comparisons now, because this is more recent data from 4 years ago. And here, Ravaglia is comparing surgical lung biopsy to transbronchial lung biopsy. 150 patients surgical, 297 transbronchial. And the length of hospital stay was significantly less in those that got the transbronchial cryobiopsy. And the mortality was over 10-fold less in those. So certainly a reason to consider. Now the diagnostic yield was higher with the bigger piece of tissue, but it wasn't bad. It was almost 83%. But there was a statistical difference between those two. But it was pretty good with the transbronchial biopsy. A more recent paper by Tomasetti et al., again, out of an Italian group, looking at about 60 patients in both groups. And they're looking at the confidence of the MDD in their approach. And they're particularly looking at idiopathic pulmonary fibrosis here. And the kappa between the three pathologists was better for the surgical biopsy than it was for the transbronchial biopsy, but considered good for the transbronchial biopsy. IPF prevalence was pretty similar in both of these groups of patients. But did it lead to a reclassification by the MDD? And there, the number is pretty similar, 19% versus 17%. So, as far as classification from an MDD, the transbronchial biopsy was just about as good as a surgical biopsy. And changing to the high confidence diagnosis there is very, very similar. So that's a little food for thought if you're trying to decide for yourself while the guidelines are mulling this over, what you want to do with your patients. And then we can move on to something that was just published this year, the coldest trial out of Australia. Here they took 65 patients and they did a cryobiopsy and a VATS biopsy in the very same patient. And the histologic agreement was not bad at 71%. Wasn't perfect though, between the two. But the concordance for those with a high or definitive diagnosis for UIP was 95% between these two. So, this in my mind argues that the cryobiopsy is just about as good as the VATS biopsy. However, there were some patients in which there was a lower unclassifiable MDD prior to the biopsy in which the surgical biopsy led to reclassification. So that was what, maybe 10% of the patients? Okay. Could we do something to improve upon our ability to use the cryobiopsy and make it a little bit better? And this is a paper by Fayez Kher in our group that was recently published. And here he combined radial ultrasound with the cryobiopsy. And he was getting yields 92% using this methodology. So, here he's localizing his biopsy site a little bit better. This would need to be validated in a larger study over multiple centers. But again, some fun food for thought. And then moving on now to Genomic Classifier, because this is really the latest thing on the scene, but it's really not all that late. Naftali Kaminsky's group published a decade and a half ago that they could differentiate using genetic analysis between IPF, nonspecific interstitial pneumonia, and hypersensitivity pneumonitis. So it's really not a new concept. It's something that people have been mulling over for a long time. But now we have a company, Veracyte, that's making this product called Invisia, in which transbronchial biopsies are done with a cup forceps. That's something anybody can do in their pulmonary practice. And you pack it up in a cooler and you ship it off to the company. And so using RNA-seq, next generation sequencing, and machine learning, they were able to identify this unique set of 190 genes that can differentiate UIP from non-UIP. So, as opposed to the interpretation thing, this is a 0 or a 1. It's UIP or it's not UIP, and that's the report you get. So what's the sensitivity and specificity? And this is combining two publications in fairly high impact journals where the specificity is 92% and the sensitivity is around 60%. So this is another tool in our tool chest in order to at least differentiate UIP from non-UIP. We've done a little work with this on our site. This is prior to the second publication by a large group. But this was 24 patients where we're looking at the confidence in the diagnosis. We had 2 MDDs. This is the data for MDD1. So MDD1 got to look at things sequentially. They met and they said, well, do we think this is idiopathic pulmonary fibrosis or not? Then we got to look at the cryobiopsy, and then on top of that, we got the result of the genomic classifier. And you can see with each step, there's an improvement. To the left is all patients, and to the right, or the middle, I should say, is patients who had a pattern that was probable. You can see there's a big improvement by adding the genomic classifier in our confidence. Those that were indeterminate or alternate diagnosis, the classifier didn't add a lot to us, mostly because it wasn't UIP. So you get a result that's negative for UIP, and you already thought it was negative. So yeah, it doesn't change our confidence very much in that group. But we're looking at 2 MDDs here, and we're comparing histopathology with the genomic classifier and the overall agreement between ourselves and the final diagnosis for IPF. And so, in this group in the middle, those with probable or possible, the genomic classifier, at least for us, performed pretty well. This may be something that you want to do at your own site to see how your group performs with this. And so that's highlighted here. So, this was, version 1 of the genomic classifier. I don't know what's coming forward, but this is work that Justin Oldham gave me permission to show you today. And this is in regard to using the Envisia classifier in 97 patients from 4 different centers. And this has been submitted for publication. And 30 of them were negative and 30 of them were positive for UIP. But let's look at outcomes based upon whether they had a positive or negative for UIP. We're looking at progression-free survival, and we're looking at time. And so it's looking here, and this is statistically significant, that the positive UIP in the genomic classifier predicts a worse outcome. So if we move on then to a suggestion, this isn't from any society, this is just me making it up. How would I do things based upon the high resolution CAT scan? Well, if it was over to your left, a definitive CAT scan, then no biopsy is needed, nothing is needed. You just make the diagnosis. What if it's a probable CAT scan? Again, if it's a probable CAT scan in a patient that probably has UIP or IPF, based upon age, smoking, and whatnot, and nothing else in the history or exam that would suggest otherwise, 90 to 95% of the time, that's going to be UIP. And so maybe under those circumstances, nothing else is needed. Perhaps because of my practice, I've always got doubt with a capital D when a patient comes in. Am I missing something? Is there something else that's a little bit odd about the way this is presenting? Maybe the patient's a little bit younger. Maybe I heard some pops and squeaks. Maybe I didn't. Something in the history that made me feel a little less confident. And so in those patients currently, I'm satisfied going ahead and just doing the transbronchial biopsy for the genomic classifier. And if I don't get the result, then come back for tissue. What about those indeterminate scans or those that are possible? So again, I'm separating out here, those where I think the clinical context is very much in line with IPF or a biopsy that I think is going to show UIP. On those patients there, one can maybe just move forward with the transbronchial biopsy with the genomic classifier. But in the remainder of patients, and really the largest group here, I might do both together at the same time, the genomic classifier and the cryobiopsy. And finally, with the alternative diagnosis, as I showed in our previous work, I really don't find a whole lot of utility in regard to confidence in diagnosis by adding the genomic classifier. So we would either go with your choice of the surgical lung biopsy or the cryobiopsy. So we're moving on to treatment, and certainly we have to, when we think about treatments, we have to think of impacts by someone that I consider a pulmonologist. And of course, this is Archibald Cochrane, a Scottish-born physician, did much of his work in the United Kingdom with coal miners, and of course TB was very prevalent at that time. He was captured in battle in Crete in World War II and worked in a POW camp, and realized at that time that he didn't really know, wasn't quite sure what he was doing with a lot of his patients. So he moved on to these thoughts of evidence-based medicine. And he's giving us a look here because the guidelines in 2000 for treatment of patients with idiopathic pulmonary fibrosis was a suggestion to treat with prednisone and azathioprine. And here we're seeing that turns out to be that wasn't a very good suggestion. We're looking at the Panther trial, where we looked at azathioprine and prednisone along with NEC compared to patients who were getting placebo. And in this group here, we have time to death or disease progression, or time to death or hospitalization. In all of these groups, it was statistically worse to be on prednisone and azathioprine. So we probably weren't doing the right thing. So now we have these FDA approved therapies. That's been since October of 2014. Both of these were approved on the same day. They have different mechanisms of action. Their efficacy in the trials was very similar, a 50% reduction in the loss of forced vital capacity over time. There are some differences in the regimen, in the side effects, and interactions with other drugs, but they tend to be very few other drugs where there is interaction with. Both of them require some monitoring for liver function test elevation, but the vast majority of patients do not have any elevation in their liver function studies. This is some of the data that supported the FDA approval. This is the Impulses phase 3 trials. They're just two trials that were done at the same time, because the FDA likes you to have two trials that say the same thing. And this is pretty much saying all the same thing. There's a 50% reduction in the loss of forced vital capacity over time. Since that was published, there's been numerous papers that have come to light. The tolerability seems to be good for patients who weren't allowed in the trial because their lung function was too poor for inclusion. Seems to work equally well for patients with real mild disease. Seems to work well if honeycombing isn't present. Works just as well if there's a little bit of emphysema involved as well. It may prevent acute exacerbations or reduce them, and it may reduce online mortality through pooled analysis. And so, definitely I said may in both of those. Statisticians don't like pooling things like that. Now, very recently, just in the last year now, we've got this progressive pulmonary fibrosis. So it was approved for IPF, but what about these other diseases that are progressing? Rheumatoid arthritis, patients with scleroderma, patients with hypersensitivity pneumonitis, or what about that 1 in 8 patients that's not classifiable? Those patients may get worse over time too. And so this is a cohort of patients that were getting worse over time over a period of 2 years. And what we're seeing here, just in a nutshell, is the nintedanib was just as effective in this progressive pulmonary fibrosis cohort of patients. So now nintedanib is approved for that as well. Looking at the other drug, pirfenidone, very similar in its efficacy in reducing the loss of lung function, the forced vital capacity over time. And so in the interest of time, we're just going to focus on that. And just as with nintedanib, pirfenidone has had further publications come to light. Tolerability is there for patients who had worse pulmonary function, works just as well in the mild patients. A longer term safety data is available for this medication. Maybe a reduce in the respiratory related hospitalizations, and similar to with nintedanib, if you pool everything together, there may be this reduction in mortality. And so here's looking at a study that was just recently published by Toby Maher, looking at pirfenidone in this unclassifiable pulmonary fibrosis group. I think there'll be other cohorts with other progressive fibrotic lung diseases forthcoming, but here we're seeing that in this unclassifiable group, there was a significant reduction in the loss of forced vital capacity over time. So the indications for these antifibrotic medications for interstitial lung disease are expanding. And this is some work, Andreas Gunther was the first author on this, and this is the European registry looking at the change in mortality over time. Now the old data would have a line further to the shifted to the left with a mortality of 3 to 5 years, maybe tending more toward 3 years. Those that were untreated in the green line here in the same epoch then, had a mortality of around 5 or so years, and those on antibiotic treatments, it was 8 years or better. So it does look like these medications might be affecting mortality. So why should I treat? Well, it will slow disease progression and it may delay hospitalization or death. But it doesn't improve just mere cough. It doesn't change oxygen requirements or change the exercise capacity. But the guidelines do recommend conditionally both of these medications, nintedanib and pirfenidone, for the treatment of IPF. And I think coming forward, I suspect it will be for other progressive fibrotic lung diseases as well. Who should I treat? So let's tackle this. So when we looked at some of the registry data, both in the IPF Pro data and in the Pulmonary Fibrosis Foundation data, it seems like 60 to 70% of patients are treated, but that means that many patients aren't treated. Why weren't they treated? So one of the reasons was that the doctor wasn't confident in the diagnosis. So all that stuff we talked about earlier about diagnosis matters as far as whether we're going to get to treatment to help our patients. Another big reason was that disease was pretty mild. And so since the patient wasn't having much in the way of symptoms, they weren't going to go on a drug at that time. But even though their symptoms are mild or non-existent, they're still losing lung function over time. So thank heavens Gary Larson's back to writing cartoons again. But this is one of his older ones. And so I see this as IPF is this big sea monster over to the left, big fish, and your patient is there and you are the physician. When are you going to wait to start treating the patient to have them reduce their loss of lung function over time? We wouldn't wait to treat someone's hypertension until they had a stroke. We treated it earlier on as something to help preserve a health span. Moving on to pathobiology and upcoming treatments of the disease. Here, certainly there's a sick and senescent epithelium in many of these fibrotic lung diseases. This senescent cells secrete a senescence-associated secretory profile, which is very pro-fibrotic, and you wind up turning fibroblasts into myofibroblasts that are laying down collagen. So, through decades of work that's been done by the pointy-headed scientists, we've come up with various targets that are possibly maybe used to treat these fibrotic lung diseases. Many of these are currently in phase 1 trials. Many of these have completed phase 2 trials and are moving now into phase 3 trials. So some examples of this, and I apologize if I don't name your trial in specific, would be anti-connective tissue growth factor antibody, inhibition of alpha V beta 6 integrin, which would deal with activation of TGF-beta, inhibition of galectin 3 would be another one, administration of serum amyloid P would be another one that could be used, and inhibitors of autotaxin as well. So that's just to name a few. So notice here though that we're still a little bit fuzzy on some of this. You have these lightning bolts, and so when you see lightning bolts, we know that's a symbol of Zeus. Zeus must have something to do with this. Zeus got the lightning bolts from the Cyclopses when he rescued them, or from the abyss. But it's not a good idea to blame Zeus for anything, or even get on Zeus's wrong side, or you might wind up like Prometheus here, having your liver eaten out every night by an eagle for offending Zeus. It's interesting, that it was the liver, because the liver is an organ that can regenerate, and we don't have our lung science to the point where we can cause a regeneration of the lung. So maybe that'll be in the future, but for now, and this goes into the aspect of treatment, we want to prevent the loss of lung function over time. So I really advocate for treating early. As I've said, there's a buttload of drugs that are being studied right now. I like to remind the House staff, just what a buttload is. It's about 126 gallons, so it's less than a ton and more than a barrel. Certainly, I think buttload's appropriate classification. I'm going to highlight a couple of trials. One is this genomics applied to pulmonary fibrosis, and there's been SNPs and point mutations described in many genes. One of them, though, is TOLIP, and it appears that TOLIP may be associated with response to N-acetylcysteine. And so we're looking at patients with different genotypes here. If you have one genotype in panel A, you do worse if you're taking NAC. That's a quarter of the patients. Half the patients are heterozygous. It doesn't matter whether they take NAC or not. But half the patients have a different genotype that's homozygous, and they seem to do better with it. And so this is part of the Precisions trial, which is a collaboration by the Pulmonary Fibrosis Foundation and the NIH. Another thing I want to draw your attention to, and this is my bias, it's this Senolytics, and this is from the graduate, won the award in 1967. Dustin Hoffman's being told by a sage older individual that plastics, you need to go into plastics in the 1960s. And my bias is that maybe it's Senolytics going forward for us now. So this is part of living well to old age and preserving organ function. Our organs develop these senescent cells, shown here as these green starbursts. And not only are they senescent and behaving badly, but they're secreting factors, this profile that is making the cells around them not work as well. And so many of these factors are pro-fibrotic. So if we could remove these senescent cells, would we have better organ function? And there's one trial now that's been, it's an early trial, just 14 patients, open label, by your neighbor here in San Antonio, Anoop. And this is very intriguing data. This is the only study I know where they gave medication to a patient with IPF and they walked farther. They performed better. So, this needs to move on to phase 2 and phase 3 trials, but something to think about for the future. So in regard to management of patients with interstitial lung disease, of course, it's not just drug, education, patient education, focusing on other things that older folks get, like coronary artery disease and gastroesophageal reflux. We'll talk more about that one. Getting them their oxygen, their vaccinations, discussing what the approved therapies are, getting them involved in trials. Pulmonary rehab, doesn't improve lung function, but does improve quality of life. A quarter of patients are severely depressed, so they might need some help from your psychiatry colleagues, and maybe, God forbid, addressing these end-of-life issues. This is data from the RAP IPF trial. This is in 30 patients. Half of them got a fundoplication and half did not. And you can see in the lower panel B, these are the upper group in kind of a pink salmon color. These are the 4 patients who died who did not get a fundoplication. One died from an MI who did get a fundoplication 9 months later. But when we're looking at the forced vital capacity over time, you can see these curves start to separate. Now, I'm in the camp that I don't think that gastroesophageal reflux causes IPF. I think IPF causes gastroesophageal reflux. But if you are refluxing and aspirating and you do have IPF, I think it's probably not a good thing. So where are we now? And I like to use this quote from Martin Luther King, but he got this off of a minister in regard to our treatment and diagnosis. And it's, Lord, we ain't what we want to be, and we ain't what we ought to be. We ain't what we got to be, but thank God we ain't what we was. So thank you very much for your kind attention.
So just a reminder to all the symposium attendees, we're going to change our schedule just a little bit. So our next speaker is Dr. Susan Mathai. And at the end of her talk, we will have a Q&A session with Dr. Lasky and Dr. Mathai, and then go to our a break where you can go to virtual booths. So I would like to proceed and introduce our next speaker, Dr. Susan Mathai. So she is currently the Director of Quality at the Center for Advanced Heart and Lung Disease at Baylor University Medical Center in Dallas. Prior to that, she was at University of Colorado, and she has done a lot of research in the field of genetics and its impact on development of interstitial lung diseases. She finished her medical school at Yale University and then trained at Mass General and for her residency, and then completed her fellowship at University of Colorado and worked with David Schwartz's group, and they've done a lot of the seminal work in identifying genetic risk factors for interstitial lung disease. So I've asked her to talk to us about kind of how genetics affects interstitial lung disease and potentially how these factors also affect how patients with ILD who are transplanted fare after the transplant. So we'll proceed with her portion of the talk.
Thanks for this opportunity to talk today about the genetics of interstitial lung disease. This is a rapidly evolving area of research, and so I hope to give you a sense of what we know right now and how it can inform clinical care. So thank you for this opportunity and the invitation to speak. I have no disclosures related to this topic to disclose. And just to give you a quick outline of what we're going to talk about, I'm going to start with a case of a patient that I took care of, talk a little bit about the genetics of ILD, familial and what we used to call non-familial cases and situations, implications for treatment and transplant, and then implications for how we might talk to families about this. So this is a case of mine that I took care of a few years ago, a 65-year-old gentleman who came to clinic after he was being told that he had CT findings that needed follow-up. At the time that I met him, he had no symptoms. This is a representative slice from his CT scan, and what you see is bilateral reticular change with some areas of mild ground glass. At the time, the radiologist reported out in his read that he had a possible UIP pattern. What was interesting about his history is that his twin brother had been diagnosed after lung biopsy with IPF about 2 years prior to meeting me. The twin brother had actually quite severe disease and was undergoing transplant evaluation. The brothers had been adopted, and so there was no other family history to put it in any other further context. This is a representative slice of his brother's CT scan that shows significant, more severe reticulation volume loss and evidence of lung fibrosis. In this particular patient's case, because he had some positive autoimmune serologies and some borderline joint pains and such that made us a little bit concerned about a connective tissue disease diagnosis instead, he opted to go for a definitive answer with lung biopsy. And these are images from his lung biopsy that show evidence of significant fibrosis in the lungs, architectural distortion, and what we see here as areas of honeycombing with mucus impaction. So these cystic areas in between the areas of pink fibrosis are honeycomb cysts that were consistent with the UIP pattern on biopsy. So his clinical diagnosis was IPF, and in his case actually familial IPF given his twin brother's history. So the questions that this case brings up are, what does his family history have to do with his lung disease, and does IPF run in families? To briefly touch on the general concept of interstitial lung disease that I believe other speakers have really addressed, is that the way that I explain interstitial lung disease to patients is that there are 3 big categories of things that cause interstitial lung disease and pulmonary fibrosis. One is things that your lungs are exposed to. The second is systemic diseases like autoimmune diseases and sarcoidosis that can cause damage to many organs, but often also the lungs. And then the third is the category where idiopathic pulmonary fibrosis and other of these quote-unquote idiopathic or unknown cause diseases come from. And what I'm going to show you today is that in many instances, what we used to call idiopathic may actually have a genetic basis in terms of risk. And that as we learn more and more, this genetic these genetic risk factors may actually be common to the other two large categories of interstitial lung disease as well. And more importantly, this slide is here to remind us that diagnosis of this, giving a patient a specific diagnosis of their ILD is really based on a true synthesis of history, physical exam, radiology, labs, and pathology. I put this slide up here to remind us all too that idiopathic pulmonary fibrosis, which is the canonical ILD, so the one that's been studied probably the most rigorously, especially from a genetic standpoint, is unpredictable in terms of prognosis, but overall poor. So IPF patients have very unpredictable clinical courses. Some of them have rapid progressions after getting their diagnosis. Others have much slower disease progression, and yet others have a sort of start and stop kind of clinical prognosis that follows declines after exacerbations and other acute changes in their symptoms. I put this up here to point out that in all of these cases, the disease is slowly progressive, either slowly or quickly progressive. And so that's why early diagnosis and getting treatment and a potentially transplant evaluation early is really important. Our IPF treatment options, which currently FDA approved treatments are nintedanib and pirfenidone, do slow down disease progression, but do not reverse it. And that is why transplantation is an important part of the IPF patient care package. And because we don't have a cure for this disease or an agent that reverses pulmonary fibrosis, early detection and treatment is important. And that's why genetics are so compelling, because it may be a way for us to identify people with disease earlier and get them diagnosed sooner. So to get right into the topic of what is the data that there is a genetic basis for ILD or IPF? Well, for many decades, people have known that and observed that there appears to be families where pulmonary fibrosis is clustered. So there are multiple generations and multiple affected family members within these sort of familial cases. And that's been reported since the 1980s. And in one study for many years ago, the strongest risk factor for IPF was actually found to be a family history of the same. So this got people to start thinking, well, we call this idiopathic, but could there be a genetic component? The pedigrees that are shown on this slide are from a project that from a paper and a project that I worked on with my mentors at the University of Colorado where we studied some families that had multiple affected family members, and which are denoted by the circles and squares that are filled in as black. And so you can see in these families, some of which are quite large, we see pulmonary fibrosis popping up in multiple generations and multiple siblings, even within the same nuclear family. So scientists started looking at potential genetic causes, and the first clue was to follow the lead of pediatric ILD, where pediatric ILD is probably even more rare than adult ILD. And so those cases were studied very carefully, and it was found that surfactant protein C mutations were associated with disease. And so adult scientists started looking at those genes in these adult familial cases where multiple family members were affected by pulmonary fibrosis, leading to targeted sequencing of that gene. The deficiencies had been noted in the lungs of patients with adult familial disease, and genetic sequencing revealed coding mutations in numerous families with multiple affected family members. In terms of why this is caused pulmonary fibrosis and damage, it's thought that the pro-SPC, that the pro-protein for surfactant protein C, when it is abnormal, gets retained in secretory compartments of type 2 cells, leading to alveolar instability and cell toxicity. And over time, that will lead to scarring and damage. Because of these findings, other surfactant-related genes were examined and found to have disease-related coding mutations. But these were really only explained a very small handful of families that were actually being seen clinically. The second big category of genetic mutations that familial cases allowed geneticists to discover were the telomerase and telomere related family of genes. So telomeres, for those of you that aren't familiar with them, are the coding repeats on the ends of chromosomes that protect them during the replication process. And they're thought to protect cells from senescence. So during the cell replication process, a little bit of the ends of chromosomes can sort of get left off when they're replicated. And so telomeres allow for the creation of a buffer zone on either side of the chromosomes that protect the important coding material on the more interior parts of the chromosomes. And so telomerase is the enzyme that creates telomeres. And so it's thought that this telomerase protects the cells and your tissues from damage over time as it replicates to refresh itself in any given organ. Early family studies, again, using these highly enriched families, showed germline mutations in TERT and TERC, with, in particular, the dyskeratosis congenita group of patients. And that's a syndrome that of aplastic anemia and pulmonary fibrosis that was easier to pick out. So it's not just your standard IPF patient, but actually patients with the syndrome that included bone marrow dysfunction. And so these family studies found TERT and TERC mutations that were associated with disease that led investigators to sequence these genes more fully in pure pulmonary fibrosis familial cases. Those coding mutations were associated with disease and with shorter telomeres. In true familial pulmonary fibrosis cases, TERT and TERC coding mutations are thought to explain between 8 to 16% of those families, and just depends on which cohort in particular you're looking at. In these coding mutation cases, there's usually an autosomal dominant type of inheritance. So you only need one mutant gene in order to have abnormal lungs. What's interesting about telomerase mutation phenotypes is that extrapulmonary manifestations are quite common and should be looked for. So often patients have hematologic abnormalities like cytopenias, thrombocytopenia, bone marrow failure, hepatic abnormalities that can vary from just LFT abnormalities to idiopathic cirrhosis, skin hyperpigmentation, and early hair graying. This picture is actually a patient of mine who I met after he had undergone a liver transplant many years ago for liver cirrhosis, and then came to me because routine evaluation had noted CT abnormalities, and he turns out to have pulmonary fibrosis as well, which developed long after his liver cirrhosis had after he had been diagnosed and transplanted for cryptogenic cirrhosis. The clinical features that should heighten your suspicion for telomere syndrome would be a strong family history of pulmonary fibrosis or bone marrow failure, premature graying, which is before the age of 25 years. So this patient had hair this color since he was in his 20s. And when I asked him about it, he and his wife were like, oh yes, absolutely. That was a weird thing that happened to me and not to any of my colleagues. Hematologic abnormalities like thrombocytopenia and macrocytosis, liver disease or abnormal liver function, a history of defective wound healing, and a history of non-melanoma skin cancers. These patients will usually have a younger onset of disease and the extrapulmonary manifestations as well. So one of the two, either pulmonary or extrapulmonary manifestations, are likely to show up earlier in life than the typical IPF patient who's diagnosed in their 7th decade of life. Overall, transplant-free survival is lower in patients with true telomeropathy, and it's the survival is about, in some studies, is 4.2 versus 7.2 years when you compare people with and without the TERT and TERC disease-associated coding variants. What is interesting is that often patients with true familial IPF or true familial ILD will have atypical features. So classic IPF is really characterized by the UIP pattern on CT scan, which shows reticular abnormality, attraction, bronchiectasis, and honeycombing without much ground glass or nodularity. And what these images show are cases of surfactant mutation patients who have biopsy-proven UIP, but their imaging is not as consistent with UIP as you might expect. The transplant implications for telomeropathy patients are debated. So it is thought that transplantation for these patients is feasible but challenging, often because they are more susceptible to the side effects of the medications that are required for post-transplant immunosuppression. There have been reports of increased transfusion rates in some of these cohorts, higher rates of renal dysfunction, and need for renal replacement therapy in the immediate post-transplant period, as well as a risk of hepatic toxicity if they are put on medications that require that have any hepatic toxicity, such as azathioprine. Pre-transplant workup considerations in a telomeropathy patient would be genetic counseling and evaluation, formal hematology involvement, and especially working with them to consider a bone marrow challenge to see what immunosuppressive agents may be more high risk for them. And of course, assessment of their liver prior to a lung transplant if they have no known liver disease. And I think that patients should know if they have a TERT or TERT coding mutation for underlying their disease, that they may have a higher rate of complications that requires closer monitoring after lung transplant. So far I've talked about what we consider familial cases. So cases of pulmonary fibrosis in which there are multiple family members that have been that have also had the disease. But what about non-familial cases? That's going to make up the majority of cases that we're going to see in clinic. The majority of patients we see don't report having a mother or sibling or aunt or uncle who had pulmonary fibrosis. It's for them a novel diagnosis in their family. So what about those cases? Is there a genetic basis for those? Well, the first clue that there certainly was that after the TERT and TERT mutations were found, people started looking at telomere lengths in patients who had just regular run-of-the-mill IPF. And what was found is that even in those without TERT and TERT coding mutations, they had short telomeres. So the short telomere was a marker of disease risk, even in the absence of a known coding mutation in those genes, suggesting that there may be mechanisms other than these coding mutations leading to shorter telomeres in these subjects and leading to their increased risk. What's fascinating is that shorter telomere length in an IPF patient appears to be associated with worse survival. So again, a marker of potential disease severity and progression. Follow-up studies started looking at using these families to find what were general areas in the genome that were common, appeared to have common changes among them, and then looking at much larger numbers of patients. And so the first common variant, and so when I say common variant, that means a genetic variant that is found in greater than 5% of the alleles out there. So much more common in the general population. Linkage analysis and subsequent genome-wide association studies revealed that there was a variant in the promoter region of the Mucin 5B gene, or the MUC5B gene, that was strongly statistically associated with disease. And this association was seen in both these familial cases as well as sporadic cases. This variant is non-coding and is common, which means that in about 20% of the non-Hispanic white general population, 20% of them will have this variant. And what we see in this disease, in this case, is that this MUC5B variant RS3570590 is associated with increased lung gene expression of this of the actual mucin MUC5B that the gene produces. This common variant association with IPF and familial pulmonary fibrosis has been replicated in numerous IPF cohorts and is probably the most robustly replicated and strongest individual genetic risk factor to explain the majority of patients that we see with IPF. Even then, only 50% of IPF patients will actually have this variant. So it explains some of the disease risk, but not all of it. The pictures here are showing that there's increased relative expression of the actual MUC5B gene in lungs of patients with the variant. And additionally, these are actually images from lung tissue from patients and the honeycomb cyst areas were showing high staining for MUC5B. How does a mucin cause pulmonary fibrosis? Well, that is still an area of a lot of debate and research, but it is thought that the excess MUC5B that's created by having this promoter variant leads to impaired mucociliary clearance. And this was discovered by using transgenic mice that produce excess MUC5B and looking at various measures of mucociliary clearance. So this suggests that in the future, something to look at would be that should mucociliary clearance or mucolytics be a therapeutic target? And that's an area that a lot of work is being done in right now. Finding this common variant associated with pulmonary fibrosis led to the use of of larger genome-wide studies to start looking for other areas in the genome that where variants were associated with disease. So follow-up genome-wide association studies found that the MUC5B gene, as well as variants in DSP and the TERT, so telomerase mutation, that gene came up with coding mutations, but there are various non-coding telomerase-related gene variants that also appear to be associated with disease. And the themes from these genome-wide association studies are that genetic variation in areas related to host defense, like mucins, cell senescence, like the telomerase pathway genes, and cell-cell adhesion, like the desmoplakin gene variants, those appear to be the general categories of genes that are associated with genetic variants that appear to be related to disease risk. It's estimated that maybe 30% of disease risk may be genetic based on these studies. Those are estimates based on lots of epidemiological data and genetic data, but of course need further assessment going forward. This is just a chart showing a list of tons of these variants and kind of, again, emphasizing that there are themes that come out of these genes. So this is not a monogenetic or a disease, meaning there are risk factors associated with all kinds of different genes, but that the theme of this is that host defense, senescence, and cell adhesion might be really important to what makes one person more susceptible to pulmonary fibrosis as they age compared to another. What is interesting is that in these genome-wide association studies, due to the size of the cohorts that they're looking at, you can actually look across the genome at whether or not the risk variants in familial cases vary from those in what we call sporadic cases, or cases where there's no known family history. And what we see is that genetically, the genetic loci that are associated with disease are the same between familial and sporadic cases, really forcing us to question that in a general sense, are familial cases and sporadic cases really different? And I think that's a question going forward in terms of how to approach their care and an area of active research. This is a schematic that it sort of tries to summarize how common and rare variants contribute to IPF risk. So rare variants like the coding mutations in TERT and TERK and the surfactant proteins are rare, meaning they're very unusual to be found in the general population, but that if you have them, the effect size or the likelihood that it will cause an individual patient disease is much higher. Whereas common variants are very common in the community, so like the MUC5B gene, present in 20% of non-Hispanic whites, those are associated strongly with the risk of developing IPF from a statistical standpoint, but having it alone does not mean that you're definitely going to have pulmonary fibrosis. It's just a risk factor. What's fascinating, and again, another area of a lot of research, is how these genetic variants are related to survival and response to therapy. The MUC5B genotype appears to be, though it increases your risk of having pulmonary fibrosis, having the variant appears to give you a milder form of disease, which is a fascinating finding, and will require more study to understand that precisely. The TOLIP common variant that has been associated with disease in the past does appear to show differential response to things like N-acetylcysteine, which is an oral medication that we used to use to try to protect patients with IPF, but overall is not used commonly anymore. What's very relevant for transplant programs is that pre-transplant telomere length is associated with post-transplant outcomes. So the probability of CLAD and the risk of death after transplant is worse if you have very short telomeres. So looking at those with a less than 10th percentile in terms of telomere length, after transplant, we see that there is a difference in terms of how they do. in this case, they looked at patients with pulmonary fibrosis of all kinds that underwent transplant, and 32% of those patients had a telomere length less than the 10th percentile. A separate study of post-transplant telomere length also showed association between shortening and worse clade-free survival. So again, telomere length appears to be a marker of potential difficulty or challenges after transplant, and a marker overall of worse outcomes. So if this is a genetic disease, are my patients' children at risk? This is a major question that comes up a lot. So we do know from screening studies of familial, in families where we screen family members of those with familial IPF, show that even in patients who don't believe that they have any disease or have never been told that they have any disease, there's about a 14.7% incidence of CT abnormalities that may be evidence of early interstitial lung disease. And a lot of these patients will progress. These cohorts are being followed prospectively really carefully. But what's fascinating is that these interstitial lung abnormalities, which are what you might consider too subtle to call true pulmonary fibrosis in some cases, but are sort of precursors from a radiologic standpoint. These are also associated with the MUC5B promoter variant. So you're more likely to have abnormal lungs of some kind if you have the MUC5B promoter variant, and you're at a higher risk of having them if you have a family history of IPF. This is true not only in familial IPF families, but also in sporadic IPF families. So one in a study where they looked at all comers with pulmonary fibrosis and offered screening to their first degree relatives, 1 in 6 relatives with pulmonary fibrosis, of patients with pulmonary fibrosis, had either interstitial lung abnormalities, these precursor lesions on their CT scan, or ILD. And this did not differ in terms of prevalence between familial and sporadic relatives. Telomere length and MUC5B promoter variants were associated with the risk of these undiagnosed abnormalities. In the general population, these undiagnosed abnormalities are also associated with the MUC5B variant in a large cohort out of Framingham. So again, pointing to their genetic variants that make the scarring response in your lungs to the environment or to life more likely. Another important finding in the last couple of years is that these common genetic variants associated with IPF appear also to be associated with non-IPF ILD, such as rheumatoid arthritis-related ILD and chronic hypersensitivity pneumonitis, in particular with the MUC5B variant and with telomere length. So is pulmonary fibrosis genetic testing ready for the clinic? So this is something that I discuss with patients on a case-by-case basis. The limitations are that the strongest disease-associated variants are common, so they're not specific on their own to diagnose somebody with pulmonary fibrosis. Like I said, the MUC5B promoter variant is present in 20% of the non-Hispanic white population. Rare variants are easier to discuss because and they should be considered for testing in the setting of people with extrapulmonary manifestations as well as pulmonary fibrosis. At this point, it's not clear that any genetic variant has implications for FDA approved treatment, so it doesn't help us pick between nintedanib or pirfenidone. So that is an area where a lot of prospective study is needed, and future clinical trials should stratify by genetics so we know whether certain drugs work better for certain people. So that will be hopefully something that we start to see data about in the next few years. So as a routine, I don't recommend genetic testing in my clinic for the average patient, but if they have a strong pulmonary family history of it and in a suspected telomeropathy, that genetic information could be important to share with relatives, children, to help them plan and know about their risk. So that's a moment for shared decision making. In the case of my patient that I started this presentation with, we talked about whether to do genetic testing, but he opted out of it because it would not, for him, change management. And we focused instead on getting him on antifibrotic treatment and monitoring for potential need for very expedited lung transplant referral and evaluation given his brother's clinical course. We monitored his other labs, in terms of hepatotoxicity and such very carefully. And I talked with him and his wife at length that his first degree relatives should monitor themselves for symptoms and have a low threshold to get seen for respiratory complaints. So in summary, there are genetic risk factors for interstitial lung disease and IPF. These include common variants that are common in the general population and increase a patient's statistical chance of having pulmonary fibrosis, but in and of themselves do not mean that a patient will develop pulmonary fibrosis. And there are also rare genetic disease-associated variants that are very unusual to be found in the general population and have a higher influence on an individual's risk of developing pulmonary fibrosis, and in the case of telomere-related genes, other organ abnormalities. Familial IPF tends to have an earlier presentation and worse prognosis than cases that present as what we call sporadic or non-familial IPF. Telomeropathy, which refers to multiple organs affected by a TERT or TERK mutation, coding mutation, are associated with poor overall prognoses and poor post-transplant outcomes. Short telomeres themselves may be also a marker of high risk in the post-transplant period. Genetic testing is a moment for shared decision-making between the physician and the patient and their family. At this time, it may not influence specific treatment decision-making and can be costly from an out-of-pocket cost perspective. And so for that reason, it's a moment where we really need to discuss how a patient and their family would be able to both pay for and interpret that genetic testing. Most importantly, first-degree relatives of patients with pulmonary fibrosis are at a higher risk than the general population for developing pulmonary fibrosis themselves. And so I always recommend that patient family members monitor themselves and their symptoms and don't wait to get help and evaluation if they develop any breathing problems. So I want to say thank you for the invitation to speak, and I'm always happy to discuss cases anytime. So please reach out to me via email or phone. I want to say thanks also to a whole host of people who mentor me and support me. In particular, my husband, Dr. Christopher Sagakis, who's a radiologist, who is particularly interested in ILD. And I want to thank everyone at Biopsy and at the University of Colorado National Jewish who helped to train me. So thank you.
Okay, great. Thank you very much, Susan. That was a fantastic talk and a great summary of the state of the art. I think we have some time at this point for a quick Q&A session. And so we're going to invite our first two speakers to join us on Zoom. And anyone with a question, please feel free to use the Q&A feature on Zoom to submit questions that you may have. I'm going to open it up. So my first question for Susan is, so do you have, in people who you suspect need genetic testing, how do you go about it? Do you have kind of a stepwise approach, kind of a common, variants panel, and then maybe digging deeper if, the initial screen comes back negative? What do you typically do with patients like that?
For the most part, there are different panels, like especially associated with groups like the Johns Hopkins group that did a lot of the original, like a lot of the telomeropathy work. When you're looking for coding variants in TERT and TERK, that are so in those cases, it's useful to send out testing to labs that have genetic testing specific to TERT and TERK, but there are a few different ones that are available, and you kind of have to look at what they're looking for. So I recently, since coming to Biopsy, there was a patient who didn't really have a telomeropathy phenotype, and I looked at the panel that right now the lab at Biopsy has easy to send out, and it has a lot of the coding variants for TERK, but then and TERT and TERK, but then doesn't, and has some of the common variants, but doesn't even include the MUC5B variant. So this is why I think it can be challenging, because you really have to want to look at what data you're going to get back, because really depending on the institution and what tests, you really want to look at the variant list and then look at what the implication of that variant is. And that's where the challenge is for somebody in clinical practice in terms of figuring out when and what to send. But there are a few different institutions. The one that comes to mind for sure for like the Turk variants would be because they've done so much research in the telomeropathy area would be the Hopkins group, but that's there are probably a number of other ones.
And do you foresee that being easier to access for kind of in the community, or is it still, kind of something you would recommend more expert guidance for?
I think that the expert guidance is really to what value, like how you're going to interpret it or how you're going to like talk to your patient about it. Because like I said, a lot of times I'm curious what Dr. Lasky's experience has been with having seen patients for more years than I, but I mean, a lot of times insurance isn't going to cover this. So, it can be like $1,000 that it's going to be a charge to patient. And unless you know how that's going to influence your care of that patient, unless they have family members that are going to get actively screened because of the result, you don't want to put that financial burden on someone. So that's kind of, and I'll be honest with, and this can be a moment of debate, especially to hear from you guys from the transplant side. One of the things that I worry about sometimes is let's say I sent a panel that included some a variant in TERT or TERC, whether or not it's coding. I want to know that that may affect how a transplant program if that's in somebody's chart, how they evaluate someone. And as an individual physician for an individual patient, I also I think about that a lot too. Whereas right now, at least at our program, I don't know what it's like in Houston, but they do not take into account genetic variants in their, like, as a standard pre-transplant evaluation. So as an individual, like advocating for my patient to get listed, I almost like wouldn't want a common TERT or TERC variant to be in somebody's chart, because then Dr. Grazia might say, well, wait a minute, maybe we shouldn't list this individual person. So I think that these are kind of things that I think about, because there's so much ambiguity among how different clinicians may or may not interpret individual pieces of data in someone's chart. And so if the transplant program started doing pre-transplant TERT and TERC or telomere length measurements, I think that would be really interesting, but we'd have to look, really carefully at that data as we were discussing them during selection committee.
Yeah, that's something that we're trying to kind of incorporate into our thought and when we evaluate patients. But we don't have a, kind of a rule says that if somebody is suspected or actually demonstrated to have that sort of mutation, that they wouldn't be considered a candidate. Although it's certainly, that the data that's available so far seems to suggest they could represent a higher risk population, and maybe a new or different, immunosuppression approach is warranted in those people.
For sure. And I would not be surprised if in the coming years that becomes part of like ISHLT or other, kind of formal guidelines about how people are listed or considered. But since it's not there yet, especially for patients that might be transplant candidates, I do have that in the back of my mind as like, if it might hurt your transplant chances, then we should think carefully about whether to find out this data.
Joe, I think in towards the end of Susan's talk, she had mentioned, perhaps incorporating kind of this more genotyping data into stratifying these clinical trials and trying to have a more nuanced approach to these clinical trials. Where do you think that fits into today's paradigm? And are we going to get there anytime soon, or is it still, something that people talk about?
In terms of picking therapeutics?
Am I muted?
No, I think I can hear you.
Okay.
I'm sorry. Did you say, do you mean like incorporating into picking which medications for patients?
Right. I think that was a question for, I just wanted to see what Dr. Lasky thought, in terms of, the clinical trial world in pulmonary fibrosis. If we're talking about stratifying patients more by their genotype and trying to, kind of develop a more nuanced approach to therapy, how close are we to being able to push that forward to the clinic?
I think we're in our infancy in this regard. I think, there's always a lag between what scientists do and our implementation of these things. We're great at figuring things out, but we're not so good at implementing them. But one example would be the Precisions trial, which is just starting now, where they're going to look at the TOLP mutations. And in those who have the favorable mutation, they'll be randomized to receiving an N-acetylcysteine or not. So, Precisions trial may bring some other information forward too. It's much broader than that, but there certainly is support from the NIH and foundations towards going in this direction of precision medicine, which will include this sort of management.
I think we have a question from Dr. Burton Dickey at MD Anderson. So he's wondering with MUC5Bs, it's a common risk allele, but it's associated with milder disease. And his question is that it's actually not surprising and it provide a low contribution to disease severity, but whereas other alleles like those associated with telomere maintenance may contribute more to severity with a higher penetrance. Is that a reasonable assumption?
Yeah, I think that, well, I mean, if I had to guess a explanation, I cannot point to anything published about this, but my guess would be that in the end, when the large cohorts have enough follow-up data, that it may shake out that there are sort of like a telomere related phenotype of disease where maybe your telomeres are shorter, or you have coding or non-coding variants in telomere pathway genes that kind of is sort of that subtype of IPF, and maybe the MUC5B subtype is like we're saying, like it's a higher risk of having some disease, but it's not quite as severe as sort of a telomere related disease. And so I think kind of the same way, and I make this analogy I think a lot of other people have said some similar things, is that it's in the same way, a long time ago we used to call lung cancer, and that it was all lumped together. But now it's like there is this variant kind of adenocarcinoma versus the other variant. It's going to totally change how we even talk about the disease. So it won't be IPF, it'll be mucin related fibrosis versus telomeropathy related fibrosis. And I think that just hasn't been really clearly delineated, but I think that's the hint that that Dr. Dickey is sort of getting at, that I think a lot of us sort of expect that might kind of be how it shakes out. I don't know if Dr. Lasky has other thoughts about it, since I know, I'm sure he's been involved in some related research. So.
I don't have much to add to your elegant explanation of where we're going, and I think you're right on the mark. But we're some years down the road from implementation in that regard. It would be great if we had a drug. Let's say that someone did have an accelerated loss of telomeres, that we had a drug that we could give to preserve telomeres, and who knows, maybe that day is coming.
And I have a question for both of you. So this is just kind of a, I don't know, I guess a hypothetical. So what do you think? Do you think we're maybe too biased by our current nomenclature of disease? Instead of looking at through kind of a a genetics lens, or kind of a pathological lens. I mean, you got to look at it through kind of a different viewpoints, right? So different people, like the pathologist or the radiologist and such, we all view it through maybe a little different lens. We're looking at the same thing, but we're seeing different parts of it. But is our kind of current nomenclature system for interstitial lung disease sufficient, or do we need to kind of have more of a molecular classification of disease?
Yeah, I think that the nomenclature around ILD has always in many ways left something to be desired, because in part because of the complexity, and Dr. Lasky's talk sort of got at that, at how there's like UIP, but UIP can be found in other diseases, and so it actually it can be very obfuscating for non-ILD specialists, even to attend an ILD conference, because it sometimes feels like we're just speaking in gibberish. And so I think things have gotten, people are working to make it better, but I agree. I think probably in like, I don't know how many years it'll take, but I think that because especially now that we're starting to see that certain variants like the MUC5B promoter variant and things like telomere length are associated with non-IPF ILDs, like hypersensitivity pneumonitis and Ra Ild are the two that come to mind that have been published about so far. That in all likelihood, at some point, the molecular markers may maybe more end up being more useful in terms of both predicting prognosis, and also now that we see that antifibrotics are effective in non-IPF ILDs as well as IPF, may help us pick when, like, or dictate therapy, because we used to sort of split among like we still do split a bit between what's the cause, like is it because you're exposed to mold, or is it because you have RA, or is it because you have nothing and then you're IPF. I mean, now we're seeing that there are more commonalities genetically between certain subphenotypes. So it would not completely shock me and to imagine in 10 or 15 years, like the entire, like a reorganization of how the disease is even named, and subsequently how it's treated.
Yeah, it's kind of rough. We let the pathologists name things, and we get into a mess. I mean, the lung, why is it called a lung? Because it floats. The lung does much more than float. And the same thing with IPF. We debated in the literature, what does idiopathic mean? Does it mean we don't know anything about it, or does it mean that it's a disease all to itself? I recall at one point when we were at the Guidelines Committee, International Guidelines Committee, suggesting that we change the name of IPF to YDGOPF, which stands for You Done Got Old Pulmonary Fibrosis. I've never been invited back since, by the way. But there's a lot of these things actually will focus in regard to fibrosis, and it ties into senescence. So I can elaborate. I mean, you can get old or senescent by going around the sun a lot of times, or you can be road hard and put away wet. That means smoking cigarettes, which is a risk factor for all of these things. We know that men tend to get IPF a decade earlier than women. We know women age better than men. And then we have these other things that we do find a mutation that's related to early senescence of the lung. And so, in regard to these aspects of things, it's messy, it's complex. Maybe things will change in the future, but let's not let the pathologists pick out the names next time. Look at sarcoidosis, meat-like. I mean, can we do better than that?
Great idea. All right, I think that comes to the end of our Q&A session. Well, I want to thank both of you for sharing your expertise with us. These were very great talks, and take a 15-minute break and move on to the next part of our session. Thank you so much.
Thanks for inviting me.
Okay, so we're back. I was notified I wasn't speaking loudly enough, so I'm going to try to fix that for the second part of our meeting. So our next speaker is Dr. Elizabeth Volkman from UCLA. She is currently an assistant professor. She's in the Division of Rheumatology and is one of the rare rheumatologists with a very active interest in connective tissue disease-associated interstitial lung disease and a recognized expert in the field. She's the director of the Scleroderma Center at UCLA, and today she's going to share with us, talk to us about the diagnosis and management of connective tissue disease-associated interstitial lung disease.
I'd like to thank you for the opportunity to present to you about the diagnosis and management of connective tissue disease-related interstitial lung disease. My name is Elizabeth Volkman, and I'm an adult rheumatologist at the University of California, Los Angeles, where I direct our scleroderma program as well as our CTD-ILD program. These are my disclosures. And here are the objectives for the talk today. So we're first and foremost going to try to understand the prevalence of interstitial lung disease in the setting of connective tissue disease, review the key radiographic features of CTD-ILD, understand how these diseases present clinically, and then finally review the treatment options. When we think about pulmonary manifestations of CTD, there's actually a myriad of manifestations that can occur. So there can be pleural disease, you can see parenchymal lung diseases as listed here. Patients can have diffuse alveolar damage, pulmonary hemorrhage, as well as airway disease. And across the spectrum of connective tissue diseases, you can see that all of these pulmonary manifestations occur throughout the spectrum of CTD. So this talk is going to focus on the parenchymal lung diseases, and specifically we'll go through each disease listed here: rheumatoid arthritis, systemic sclerosis, myositis Sjogren's, mixed connective tissue disease, as well as lupus. The most common pattern of lung disease associated with CTD is the NSIP pattern, and the hallmarks are listed here. When you see NSIP, it's most often related to connective tissue disease, even more often than idiopathic NSIP. The second most common pattern of lung disease that we see in the setting of CTD is UIP. And in contrast to NSIP, there is often minimal to no ground glass. There can be asymmetry in its involvement, and typically there's honeycombing present. So this is actually the most prevalent pattern that we see in the setting of rheumatoid arthritis. The presenting symptoms of a connective tissue disease-related ILD can vary, and sometimes patients can just complain of fatigue on exertion. Many patients can even be asymptomatic. And it can be challenging to distinguish between symptoms related to pulmonary disease and extrapulmonary symptoms. So in a patient, for example, with active inflammatory arthritis or myositis, their extrapulmonary symptoms may impair them from exercising, so it can be difficult to assess whether the patient has dyspnea on exertion. So this is why we typically recommend high-resolution chest CT to screen for the presence of ILD in the setting of connective tissue disease. And we use this protocol here. It's especially important to obtain prone imaging, particularly when you're screening for early ILD, and you want to make sure it's non-contrast with inspiratory and expiratory phases and thin sections. Pulmonary function testing is also important to do at the onset, and this is not a sufficient way to screen for the presence of ILD because PFT testing can be normal in early ILD, but it's helpful for establishing baseline severity as well as establishing baseline lung function so you can monitor the patient moving forward with pulmonary function testing and assessing disease progression. Again, on this type of testing, we typically see restrictive physiology. We often use blood antibody tests to help phenotype the patients, and I'm going to go through this in more detail as we go through each CTD. And then finally, it's very important to do a careful history, symptom assessment, and physical exam, as well as to assess oxygen desaturation and 6-minute walk test distance. But even when you have a patient with connective tissue disease who presents with an ILD, it's not always related to connective tissue disease. And this is not an exhaustive list, but it's a number of the diagnoses that can be associated with an interstitial lung disease. So you can certainly have a patient with systemic sclerosis who has ILD, but the pattern can be more consistent with hypersensitivity pneumonitis. So it's very important in these patients to do a thorough evaluation, including a multidisciplinary discussion. So multidisciplinary discussion typically involves rheumatology, pulmonary, thoracic radiology, pathology, as well as respiratory therapy. And at UCLA, we actually meet weekly to review all of our outpatients with ILD, as well as select inpatients with ILD. And we do this so we can develop a diagnosis based on consensus and formulate a treatment plan. A number of studies have demonstrated the benefits of a multidisciplinary discussion, which are listed here. And namely, this approach has been found to increase diagnostic confidence by refining a provisional diagnosis, as well as increase diagnostic precision. So now let's go through the prevalence of ILD within the specific CTDs. And you'll see on the subsequent slides that there's often a range that's reported. And this is because the studies that assess for the prevalence of ILD and specific CTDs vary in terms of their methodology. So some of these studies use high-resolution chest CT to screen for the presence of ILD. Others use pulmonary function testing or symptom assessment, and some screen patients very early in the disease and some later, and this obviously can have an impact on the reported prevalence. So for rheumatoid arthritis, for example, the range is anywhere between 30 to 76%, which is what has been reported in the literature. In systemic sclerosis, we probably have the most research on prevalence, and most of the studies are reporting, the ones that use high-resolution chest CT, that the majority of the patients, so definitely between 55 to 65%, even over 65%. Sjogren's syndrome is a smaller percentage, but again, this is what we have in the literature. It may be larger than this. Myositis, the range is 23 to 65%. Lupus is much lower. And then again, mixed connective tissue disease, there's also a large range there. So now let's go through the specific CTDs, and we'll start with RA-ILD. So as I mentioned previously, the most common radiographic pattern that we see in the setting of RA-ILD is UIP. But after this, you can see NSIP, bronchiolitis, as well as organizing pneumonia. And this was based on a study where patients underwent biopsy, and the CT findings reflected the pathology findings. The risk factors for RA-ILD include male sex, older age, cigarette smoking, higher levels of rheumatoid factor, the presence of the anti-CCP antibody, as well as specific HLA alleles. Most often, the ILD will present in a patient with established RA. But in some patients, and in fact about 10% of patients, ILD can be the presenting feature, and the arthritis develops after the ILD occurs. The risk factors for progression include the presence of UIP, a lower FVC-DLCO at baseline, a higher rate of change of FVC-DLCO in the first 6 months, as well as increased disease activity. And the presence of ILD can have a profound impact on survival in these patients. So this was a study that was done, and in this study they found at 5 years after the first diagnosis, about 36% of the patients had died, and the median survival overall was 7.8 years. So in fact, after cardiovascular disease, ILD is the second leading cause of premature death in patients with RA. It accounts for 6 to 13% of excess mortality, and this increased mortality is due to respiratory failure from ILD progression as well as infections. Another thing that can happen in RA, and it's quite rare, but when it does happen, acute diffuse alveolar damage has a very poor survival with only 2.4 months on average. How do we treat RA-ILD? Well, obviously smoking cessation is very important. Steroids are often used, but there's an unclear benefit in this population, and obviously you expose the patient to an increased risk of infection, so we typically use these sparingly. Mycophenolate is often used first line, but this is a drug that does not work very well to improve inflammatory arthritis as well as our other RA DMARDs. So oftentimes we have to use additional things to control the arthritis when we're using mycophenolate for the treatment of ILD and RA. Rituximab is actually something that I use quite frequently in this population. There are some promising findings of rituximab improving lung function in connective tissue disease-related ILD, and we know that this is a drug that's already been FDA approved for the treatment of rheumatoid arthritis and can substantially improve joint symptoms. In addition, nintedanib has been recently approved to slow the decline of lung function in patients with progressive ILD. And in the recent InBuild trial, which was nintedanib versus placebo for progressive ILD, they did have 170 patients with autoimmune ILD. Among them, 89 had RA ILD. And this is a figure showing the adjusted mean annual rate of decline in FVC. So the dark bars here represent those patients randomized to nintedanib, and the blue bars, the light blue, represent those randomized to placebo. And you can see that across all these groups, so whether they use DMARDs at baseline, yes or no, whether they use steroids at baseline, yes or no, there still was a significant treatment effect across these different subgroups. Medications to use with caution include methotrexate, leflunomide, as well as the TNF inhibitors. And there's no evidence that using methotrexate in a patient with RA increases their risk of developing ILD, but obviously, there's a risk that in a patient with established ILD, if they develop pneumonitis, it can sometimes be difficult to distinguish pneumonitis, especially if it's a subacute form of pneumonitis or chronic form, from progression of ILD. So we typically stay away from methotrexate and leflunomide in someone who has established ILD in the setting of RA. And again, the tumor necrosis factor inhibitors, there are some reports of new ILD or ILD exacerbation. So again, we use these with caution as well. So now we're going to transition to scleroderma, and the most common radiographic pattern in scleroderma is the NSIP pattern. The UIP pattern can occur, but it usually occurs in only 25 to 40% of patients. The risk factors for ILD in the setting of systemic sclerosis include male sex, African American race, diffuse disease, as well as the presence of the SCL70 antibody or the PMSCL antibody. In terms of ILD onset, it's helpful to consider the trajectory of the skin involvement in patients with scleroderma. So over the course of the first 5 years in patients with either diffuse or limited skin disease, we typically see ILD occurring early, so within the first 1 to 2 years. And this is important because this is the optimal time to screen these patients, again, before they experience progression of their lung disease. We know a lot about the risk factors for progression of ILD in the setting of systemic sclerosis based on both observational trials and clinical trial cohorts. So in terms of demographic characteristics, increased age, male sex. In terms of biomarkers, we have elevated CRP, KL6, CCL18. Obviously, lower lung function and lower DLCO at baseline is a poor prognostic factor, but even more important than that probably is the change in the FVC and DLCO within the first 1 to 2 years. The antibody, the SCL70 antibody or diffuse SSC, and then those patients with increased extent of ILD on HRCT. ILD is the #1 cause of death in patients with systemic sclerosis, and the mortality is most often due to respiratory failure from ILD progression. And not surprisingly, the prognosis for patients who have comorbid pulmonary hypertension is worse. So how do we treat these patients? So the scleroderma lung study 2 was a large randomized controlled trial comparing oral cyclophosphamide for 12 months followed by placebo versus mycophenolate for 24 months. And this study looked at the course of the FVC percent predicted over 24 months. And this study found that actually there was no significant difference in the course of the FVC between patients randomized to mycophenolate versus cyclophosphamide. You can see that both treatment arms experience improvements in their FVC, and these stars here represent significant improvements from baseline. This slide here demonstrates the change in the FVC percent predicted, and you can see that about 65% and 72% of patients in the cyclophosphamide and mycophenolate arms respectively experienced an improvement in their FVC. And the average change of improvement was about 3%, which is consistent with the minimal clinically important difference needed in FVC in this patient population. In addition, both of these drugs improve the patient's skin disease, their self-reported dyspnea, as well as radiographic fibrosis. Another option is nintedanib, and the Census trial was the largest study that's ever been done to date, looking at nintedanib versus placebo for the treatment of adult SSc-ILD. In this study, patients, in order to be enrolled, had to have greater than or equal to 10% extent of fibrosis on HRCT. And the primary outcome for this study was the annual rate of decline of the FVC over 1 year. And the key secondary outcomes included the skin score, the MRSS, as well as the St. George's Respiratory Questionnaire. Importantly, patients in this study were allowed to take background mycophenolate or methotrexate as long as it was given at a stable dose for about 6 months or more. So in fact, almost half of the patients in the study were taking mycophenolate when they enrolled in the trial. And this is, again, the mean absolute change from baseline in the FVC. And the light blue line here is placebo, and the dark blue line is nintedanib. And you can see after about week 12, these two lines diverge, and there was a significant treatment effect favoring nintedanib over the course of 52 weeks. I think it's important to keep in mind that those patients who were taking mycophenolate at baseline, in this subgroup of patients, there was a difference, still a treatment effect, but it was not statistically significant. The patients that derived the greatest treatment effect were actually those patients not taking mycophenolate at baseline, and this was a significant difference. In terms of the secondary outcomes, there was no effect on MRSS, no effect on the St. George's Respiratory Questionnaire, and I think it's notable to report that 76% of the patients in the nintedanib group experienced diarrhea versus only 32% in the placebo group. And then finally, there's a lot of other treatment options on the horizon for SSc-ILD, and we don't have enough time to go through the evidence for each of these, but I will say that rituximab is, again, something that we use a lot in patients with refractory SSc-ILD. It's also been found to help improve skin score, and there's currently a randomized controlled trial ongoing in the UK comparing rituximab to cyclophosphamide for the treatment of CTD-ILD, and a large percentage of the patients in that trial have systemic sclerosis. Tocilizumab is another drug that's been studied, and there was a phase 3 trial designed primarily to look for improvements in skin disease in patients with diffuse systemic sclerosis. Unfortunately, this study did not meet its primary endpoint in terms of MRSS, but the FVC was one of the key secondary endpoints, and it appeared that tocilizumab had an effect on FVC. So this is something that in the future we may use more in scleroderma lung disease. And then finally, pirfenidone is also being studied right now in the scleroderma lung study 2. And this study compares mycophenolate plus placebo versus mycophenolate plus pirfenidone. And the hypothesis of this study is that combining an antifibrotic with an immune suppression up front may lead to a faster treatment response. So now we'll move on to myositis. And the radiographic pattern that's most common is NSIP in this disease, but you can see organizing pneumonia either alone or in combination with NSIP. Typically, the ILD presentation occurs after the diagnosis of myositis in about 40% of patients, but it can precede the diagnosis in about 10 to 30% of patients. The typical course is progressive shortness of breath on exertion over months to years, but as most of you are well aware who work in ICU settings, there can be patients who have a rapidly progressive course over weeks to months, especially in dermatomyositis. The risk factors for ILD in the setting of myositis include older age, arthritis, fevers, elevated inflammatory markers, the presence of amyopathic dermatomyositis, the Jo-1 antibodies, and then anti-MDA5 antibodies. Malignancy seems to be a protective factor for the development of ILD in this condition. And I think it's important to just call out amyopathic dermatomyositis because oftentimes when we don't see an elevation in CK and aldolase, we stop our workup for myositis. But it's really important in these patients to do a thorough skin exam. And if you're going to look anywhere on their body, it can be very helpful to look at the hands. So on the left here, you can see an example of mechanic's hands. And on the right, you can see a patient with severe Gottron's papules and ulcerations. The frequency of ILD can be largely influenced by the autoantibody profile of the patients. So you can see that JO1 or PL1, PL7, these are antibodies that are associated with a high frequency of ILD in both polymyositis and dermatomyositis. And this is by no means an exhaustive list of all the different myositis-specific antibodies out there, but I thought this was, again, a nice article that reviewed the frequency of ILD based on these certain antibodies. So the risk factors for progression include the presence of the MDA5 antibody, the SSA JO1 antibody positivity, so the presence of those two antibodies together, the pattern, so typically consolidation is something that's reversible with immune suppression, whereas the UIP pattern portends a worse prognosis. And then keep in mind that the PFTs can be difficult to interpret as a patient can have concurrent muscle weakness that can influence their results. The treatment for this condition includes steroids as well as the initiation of a steroid-sparing agent, and including some of the ones that we've discussed before. So mycophenolate, azathioprine is often used, rituximab, cyclophosphamide, and IVIG is often used in combination with these approaches. And it's important to note that exercise is not contraindicated in these patients, and in fact, pulmonary rehabilitation is a part of my treatment plan for all patients with CTD-ILD, and it will not exacerbate their myositis. So we'll move on to Sjogren's syndrome. Again, NSIP is the most common pattern, but UIP can occur. And then if you see lymphocytic interstitial pneumonia, this is often the pattern that's most commonly associated with Sjogren's versus other CTDs. And this is a nice image of one here. The risk factors for Sjogren's include male sex, smoking, older age at onset, the presence of the ANA antibody, and the presence of the rheumatoid factor. We use steroids in these patients, and similar to myositis, scleroderma, rheumatoid arthritis, we often use the following steroid-sparing agents. In terms of mixed connective tissue disease, and again, NSIP is the most common pattern that we see. The risk factors include Raynaud phenomenon, dysphagia, the anti-Smith antibody, as well as increased age. And similar to what we saw in RA, the presence of ILD has a large impact on survival in these patients. The treatment involves steroids as well as the initiation of a steroid-sparing agent, and it's really important in these patients to evaluate them and consider treatment for the presence of comorbid pulmonary hypertension. So the last CTD we'll discuss is lupus. And again, ILD is very rare in this population. The risk factors are not clear, and the course can be highly aggressive. So this was actually an example of a patient we saw at UCLA. We typically treat these patients with immunosuppression, but this was a patient who later went on to receive a lung transplant. And then finally, I wanted to discuss another clinical classification, and this is mainly used for research purposes at the present time, but this is interstitial pneumonia with autoimmune features. And what this is patients who have interstitial lung disease with some features of autoimmunity, but no definitive CTD is present. And some feel that this may represent an undifferentiated connective tissue disease. So really early signs of CTD without the full-blown CTD picture. So the definition is actually the patient has to have ILD, they cannot have a definitive CTD present, and they have to have one feature from two of the domains here. So a clinical domain, a serologic domain, or a morphological. So either, NSIP pattern on CT or on histology. So these are the clinical features and the laboratory abnormalities. And I'll just note that, again, the ANA titer has to be of a significant level in order to qualify here for a laboratory abnormality. And when you look at survival in these patients, this was a nice study done that looked at survival based on IPAF with and without UIP pattern. And you can see that without UIP, the survival is very similar to connective tissue disease, whereas with UIP, it's probably more similar to IPF. So to summarize, for this talk, we wanted to understand the prevalence of ILD in the setting of CTD, review the radiographic features of CTD-ILD, understand how these present clinically, and then review the treatment options. So really, in terms of treatment, immunosuppression is the mainstay, and the preferred steroid-sparing agents include mycophenolate and rituximab, but antifibrotics are promising adjuvant or alternative agents, and most importantly, early initiation of therapy may prevent the loss of lung function, improve morbidity and mortality outcomes in these patients. I'd like to thank you so much for your time. These are some of the foundations and organizations who funded the research I do in this area, and I'm happy to entertain your questions at this time.
Great, thank you for that talk, Elizabeth. That was a very nice summary of this sometimes quite confusing category of diseases that we deal with frequently. I think we'll save questions until the next Q&A session, and we'll just invite everybody back at that time. So for our next talk, we're going to move on to Dr. Debbie Levine. So I want to introduce Dr. Levine. She is a professor of medicine at UT Health Science Center in San Antonio. She is the medical director of their lung transplant program and also directs their pulmonary hypertension program. She is very active in the major societies that define disease management guidelines in pulmonary hypertension, within the transplant community as well. And so we would take up the rest of our time if we were to go over her CV. So I'm going to move on to her portion of the talk, and she will join us for the Q&A.
Good afternoon, and I'd like to thank Dr. Wong and the whole organizing committee for allowing me to speak about pulmonary hypertension in interstitial lung disease, challenges in identification, diagnosis, and management. This is Debbie Jo Levine from the University of Texas. I have no disclosures on this topic. Pulmonary hypertension is actually not one disease. It's an observation of a group of diseases that have elevated pressures in the pulmonary circulation. Pulmonary hypertension encompasses a diverse group of conditions that can lead to elevated pressures either in the arterial or venous pulmonary circulation. The definition of pulmonary hypertension is a hemodynamic one, and it's based on accurate findings of the right heart cath. The Sixth World Symposium on Pulmonary Hypertension definition is a mean pulmonary artery pressure of greater or equal to 20 millimeters of mercury by right heart cath. The Sixth World Symposium also set up 5 groups, which patients are classified into based on their clinical, pathological, and treatment-wise characteristics. Group 1 is pulmonary arterial hypertension, or PAH. Group 2 is the largest group of PH secondary to left heart disease. Group 3 is PH secondary to lung disease, and it's the 3rd largest group, and this is the group we'll be talking about most today. Group 4 is dedicated mainly to chronic thromboembolic PH. Group 5 is pulmonary hypertension secondary to unclear mechanisms. The rationale for developing these clinical classifications really is so that we can classify these patients into the correct diagnostic group so that we can drive the correct therapy for each patient. The World Symposium of PH also classifies patients hemodynamically. They classify patients into pre- and post-capillary pulmonary hypertension. And you can see that they take the 5 groups and really put them each within which group they best identify with in terms of hemodynamics. So group 1, 3, 4, and some people in 5 belong to the pre-capillary pulmonary hypertension group, which is where a patient has a normal filling pressure, a normal wedge or LV-EDP, and a high pulmonary vascular resistance, which was really reflecting the pathologic changes in the small pulmonary arteries. Groups 2 and some patients in group 5 are in the post-capillary group, and these patients have a increased wedge or LV-EDP, and they have a low PVR, or not an increased PVR, and that's really reflecting the passive increase in pressure based on left heart disease. Remember, group 2 is left heart disease. When you look at patients with pre-capillary pulmonary hypertension, of which group 3 is part of, we can see in this schematic that really looking at clinically and hemodynamically, the progression really follows the pathologic changes. And you can see when a patient starts off in the small pulmonary vessels or arteries, that the artery looks pretty normal. But as time goes on, you can see that that artery or that vessel becomes pretty much obliterated. As that occurs, you can see symptomatically the patients start to get symptomatic until they start to decline. Hemodynamically, their pulmonary vascular resistance goes up, and as this is happening, their cardiac output usually starts to decline at the time the patient is clinically decompensating or declining. The patient, as the cardiac output goes down, you can see that the right heart becomes dilated, dysfunctional, and leads to right heart failure, which is really what these patients have the most morbidity and mortality from. Today we're going to talk again about the PH secondary to due to lung disease. And this is a very important group. And not only is it the second largest group of PH, but also, as you can see, it has the highest mortality of all the groups. And group 1 itself has a very high mortality rate. But when you look at patients who are in group 3, secondary to lung disease, these patients have a significantly worse mortality. Today, we're not just going to talk about the whole group. We're going to talk mainly about the restrictive lung disease and really interstitial lung disease. And when we look at patients with all chronic lung diseases, so the whole group 3, which remember included obstructive disease and restrictive disease and combination of the two, we can see that those patients in restrictive disease, ILD, non-IPF ILD, and IPF, actually have the worst survival of any of these patients. So this group of patients is very, very complicated. This is just another schematic showing us that the disease progression in PH-ILD, which is what we're talking about today, is much worse than those for patients with idiopathic pulmonary arterial hypertension or group 1 PH. The red is the patient, this is percent survival on the y-axis and disease duration on the x-axis, and you can see that IPAH patients are in red, and those in blue are the patients who have ILD-PH. You can see now even more clearly that the 1, 3, and 5 year survival rates are much worse than in PH-ILD than IPAH. Look at the 5-year survival, 14% in this study from 2015. The WSPH goes a little bit further with group 3, and they talk about lung disease and looking into assessing the severity. So patients who have chronic lung disease but don't have pulmonary hypertension have a mean PAP less than 20, or they have a mean PAP greater than 21, but they have a low PVR. Patients can then have with PH, or they can have severe PH, which is when the mean PAP goes above 35 millimeters of mercury, or when the mean PAP is greater than 25, but the cardiac index is less than 2. which puts them into the severe category. What about how common PH and IPF is, or ILD? Well, I think this kind of tells us all of ILD, and really the bulk of information is coming from the IPF data. And there's multiple small single-center studies as well as multi-center data that shows us that there's a broad range of prevalence when you're looking at it. Greater than 40 studies looking at this, and you can see between 3 and 86% is really a large spread. In the U.S., the annual incidence, when you're using a narrow definition of pulmonary hypertension ILD, is about 6 to 9 of each 100K. That goes up higher when a different definition is used, basically a double to triple. The wide variation, 3 to 86%, is really based on the fact that there's variations in the way we both, number one, define pH. Is an echo or a right heart cath being used in the study? And also the way we're actually defining ILD or IPF. This is a very important topic because this is where we define PH-ILD, and it's also how we look at clinical trials and treatment. So this is a slide looking at two different ways of looking at it. In IPF, it looks like when patients are diagnosed right at IPF, there's only an 8 to 15% chance of a patient having PH-ILD. However, when patients are a little farther down the line, when they're being evaluated for lung transplant, that shoots up to almost 50%. And when a patient is being ready, at least ready to be listed or at transplant, it goes all the way up to 86%. And you know, these patients are a lot more severe at the time. There's also other studies looking at other non-IPF ILD, whether it be NSIP, chronic HP, or non-IPF ILD, which also shows a range of PH-ILD. So what is the proposed mechanisms of PH-ILD? Well, since there's probably multiple different factors really involved, it's very complex. There's some overlapping ideas, and really it's not yet fully elucidated. But we know that various factors do contribute to its development: hypoxemia, vascular remodeling, fibrogenesis, and disruption in the normal angiogenesis. And all these factors and others can lead to the decreased quantity of pulmonary vessels that leads to impaired ability to vasodilate, resulting in the increased PVR, leading to right heart dysfunction and failure. This is just another schematic kind of saying the same thing, that interstitial lung disease does help lead to vascular obliteration, leading to chronic hypoxemic vasoconstriction, again, pulmonary artery remodeling, as well as decreased vascular recruitment, leading to increased PVR, pulmonary hypertension, right heart failure, and a decreased cardiac index. So what are the challenges in PH-ILD? Well, I think we can talk about challenges in identifying it, we can talk about challenges in diagnosing it, and then we talk about the challenges that come up when we're trying to develop clinical trials as well as treatment. So I think the biggest challenge all stems from the fact that there's really no standardized evaluation, assessment, or definition regarding PH-ILD when it comes to all comers. So really identifying PH-ILD is being done in different ways in different centers, and likely even within the same center by different clinicians. So it's difficult to say how we are identifying it as a community. Again, there's significant, another challenge is there's significant overlap in symptoms between just having ILD and having PH-ILD. Remember, having a dyspnea, progressive dyspnea on exertion. That could be ILD itself, or it could be PH-ILD. That was just one example. Physical exam itself lacks sensitivity as well to predict PH-ILD. Yes, if you have patients who have worsening edema and maybe some signs or symptoms of right heart failure, that can help us differentiate that. But remember, that's already at a very late stage, and you want to try to diagnose these patients early. There's not one particular or single exam findings that can help predict PH-ILD or to predict the outcomes. Yes, there's studies looking at different combinations. One study showed a combination of edema, parasternal heave, and increase in JVP that looks like it could lead to a diagnosis of PH-ILD. But again, those are signs of right heart dysfunction. So we really need to discuss how we're going to find a way to screen and monitor serially for PH much earlier, so that we identify it early, we do the evaluation, and know where to start with treatment. This is a slide from Dr. Stephen Nathan from the ERJ 2019 WSPH guidelines that came out from the 6th WSPH meeting. And it really kind of gives us an idea of what we can do in terms of a way to start an evaluation when we're looking at these patients. So looking at signs, symptoms, and some studies, including PFTs, 6-minute walk or CPET, and imaging. We really have to have a low threshold of suspicion so that we can even be looking for it. You support that suspicion with non-invasive tests like an echocardiogram, but remember, we need to always confirm with the gold standard right heart cath, because that's the only way to truly diagnose pulmonary hypertension, whichever group we're in. Once we find that we do have patients with PH, we need to stratify them or classify them into the group classification. And the hardest thing in this group of patients is to decide, are they group 1 with some lung disease, or are they group 3 with some PH? So I think this is a really nice schematic to look at those patients who may have group 1 with limited lung disease, all the way to the other part of the scenario where the patient has severe CL, chronic lung disease, and probably has group 3. The reason is, as you'll see, the treatments are quite different for both of these. So it really is difficult to elucidate unless you go step by step. If a patient does have group 1, we know that there are multiple therapies available for these patients. Group 3, we really need to look at referring these patients to PH centers and often lung transplant centers to be able to be to either put patients in clinical trials or to look at further therapies. This is a graph that kind of goes through some of the things that maybe would favor group 3. If these studies were done and you have the results, these results would favor group 3 rather than group 1. So your history of physical, we talked about the symptoms and signs of right heart failure. Pulmonary function tests, if you have kind of stable, serially stable spirometry, but your DLCO is worsening or is below 30%, that might make you think of a pulmonary vascular disease and pulmonary hypertension. It could also help you consider a patient who has CTEPH or a PE. 6-minute walk test, if you're markedly worsening quickly or severely reduced in terms of your distance. Also, the question of doing an impaired heart rate recovery after your 6-minute walk. If your heart rate is less than 13 beats per minute difference, then you may consider pulmonary vascular disease. CT scan, there's multiple different ways you can look at a CT scan and kind of consider PH-ILD. An increased PA to aortic ratio of greater than 0.9, and some people say 1.0. The RV to LV ratio greater than 1, and then a CT scan that has extensive lung disease rather than just minimal. Again, looking at echocardiogram, when patients have end-stage lung disease, their right ventricular systolic pressure may not be accurate. You often have either under or overestimation. So looking at things like RV dilation, TAPSE, RV outflow tract diameter, as well as the fractional area of change are areas that you can look at. Laboratory tests, we know looking at BNP can also be important. This is just one of the studies looking at how we can look at CAT scans, and it's newer, so I put it in, and it's looking at survival estimates with ILD stratified by that RV to LV ratio. And you can see those that are less than 1 have a better survival than that have this RV-LV ratio greater than 1. And this is really a great schematic to kind of show you what you're looking for and how to measure it for yourself. So what about the challenge in diagnosing patients? Well, I think one of the challenges is that, remember, with ILD and IPF, or IPF and ILD, there is multiple comorbidities that can cloud the picture of what's going on. Patients with ILD obviously have pulmonary hypertension. We're talking about that. But obstructive sleep apnea, which can also lead to pulmonary hypertension, pulmonary veno-occlusive disease in patients who have scleroderma and other connective tissue disease, patients with cardiac disease, HFpEF, or even other cardiomyopathies can lead to group 2 PH. So really, and even patients who have CPFE, or combined pulmonary fibrosis emphysema, can also cloud the picture. So there's multiple challenges just by the comorbidities that occur within the disease state of ILD. This is just one slide showing us that patients with PVOD in scleroderma are not uncommon. This is a retrospective study looking at explant tissue of patients who had lung transplants for scleroderma PH-ILD. You can see that down that over 50% had mild PVOD, and 6 or 33% had moderate to severe PVOD. So it's common in certain populations. So these are things to look out for, and that might make it difficult to know what the disease state is that we have. Again, group 2, remember, the largest group of PH, it occurs quite often in patients with ILD. Patients oftentimes have HFpEF, or left heart failure with preserved left ventricular systolic function, which is important perioperatively if a patient has ILD PH and goes and undergo lung transplant. It can make it difficult sometimes. Patients have CAD and IPF. Remember, they share a lot of the same risk factors: older males, smoking history of OSA, and a wide spectrum of prevalence of CAD in IPF. So think about that as also being part of the symptoms that may come up when you're trying to diagnose IPF. This is a very important thing to look at when you're talking about things like scleroderma, that there could be direct cardiac involvement in ILD, and this may account for some of the dysfunction. It can lead to systolic dysfunction, arrhythmias, heart failure. That can be group 2. And even though sarcoid is now in group 5 pulmonary hypertension, it's also a good example how direct myocardial involvement may result in LV dysfunction, or sarcoid granulomatous disease may infiltrate the myocardium. So these are important ways that the cardiac is directly involved. This is a nice slide just showing us from patients with connective tissue disease. Really, when you think about connective tissue disease, they can have interstitial lung disease. Group 3, they can have CTEPH because of their antiphospholipid antibody problems. They can have group 2 because of the direct involvement, pulmonary veno-occlusive disease, and PAH group 1. So there's different diseases that can really include all groups of PH. What about the challenges in management? Well, there are challenges in management and looking how to manage them with clinical trials, but it all really hinges on what we've discussed before: an accurate diagnosis, really trying to decide if a patient has group 3, ILD PH, group 1, PAH, or others. And with group 1, we're okay. we have multiple approved medical therapies. With group 3, we still are understanding that we need to treat the underlying condition, oftentimes with antifibrotics and immune suppression, but then referring to PAH centers as we don't have direct approved medications. And this is just a summary of the trials. We won't go through this, but these are the trials that have occurred with PAH agents and PH-ILD. Remember, the endothelin receptor antagonists really, none of them were working well, and some of, at least the ambrisentan was terminated because of disease progression. The PDE5s and the Rio-Sequat SGC simulators had some improvement. The sildenafil and tabinib study showed an improvement in 6-minute walk, but no benefit in quality of life and BNP. And Rio-Sequat study was terminated because of early AEs or adverse events. Now, when you look at the prostanoids, we have the INCREASE trial that was released about 9 months ago, and it did show some improvements in functional class and 6-minute walk, and it didn't show worsening in PFTs and oxygenation, and that is got a PDUFA date to be evaluated for possible approval for this use in PH-ILD. Obviously, it's used now for PAH. Looking into IV treprostinil, we're looking at these as well with improvements in the 6-minute walk, BNP, and clinical symptoms. So what about if none of these things help us? We need to consider lung transplant for PH-ILD. And the thing with these patients is PH-ILD patients are incredibly unpredictable. Their course can go anywhere from stable for months to just declining very, very rapidly. So you need to refer these patients early to a center. And no center will ever say to you, oh, you referred them too early. They love that because there's a lot of things that we have to do in lung transplant centers to get them ready for a transplant. So the approximate projected waiting time may be unpredictable based on your region, the donor supply, the blood type, and the LAS of the recipient. So remember, really, timing is everything. The reason is you can diagnose a patient and refer them right away. Even the IHSLT guidelines say when you do diagnose an ILD patient, even without PH-ILD, referring them is the right time because it gives the patients time to be evaluated, time to make any adjustable changes that can happen, and see if they can get listed. If they're referred close to where they start declining, they may become too sick. So timing is everything. So when you talk about PH-ILD, remember it is a group of progressive devastating diseases, and really all are not yet completely elucidated. All are associated with significant morbidity and mortality. You saw that being the worst outcomes for patients with PH, the worst group. There's no cure. The identification diagnosis is challenging, and that makes the clinical trial development and management challenging. And it all hinges on making that correct early diagnosis. Clinical trials are ongoing, however. We're looking at multiple therapeutic options. But until then, remember, early referral to lung transplant continues to be important for appropriate patients. I want to thank you. And I will be taking questions now. Thank you so much.
Great. Thank you, Dr. Levine. That was a great summary of the current state of the art. It's actually a relief to see at least the beginning of an effective therapy becoming available because of the INCREASE trial. For these patients with group 3 disease. So we're going to move to our Q&A session, and I'm going to invite our panelists to join us on Zoom. And again, you can ask questions with the Q&A feature button. And I think we do have a question from Dr. Adani Frost. I think this one is probably for Dr. Volkman. Just regarding the census study, which suggested the use of immunosuppression kind of lessened the impact of nintedanib in mitigating pulmonary fibrosis progression. And so I think your question is that, well, there's the possibility that maybe chronic immunosuppression helps more than nintedanib, or the patients who are able to stay and tolerate methotrexate or mycophenolate for 6 months or more, which was a criteria for entry into that study. Is it helping them in some other way, either from an autoimmune standpoint, or maybe genetically they're more responsive to that therapy? Any ideas?
No, that's a great question. Can you hear me okay?
Yep.
Yeah, I think there's a lot to learn from the census trial. You know, the issue with the background therapy with mycophenolate, because most of the patients, I think 49% of them were on background mycophenolate. And because they weren't randomized to mycophenolate, it makes it a little bit difficult to interpret the results. But if you look at the true placebo arm and then the placebo arm that was assigned to mycophenolate, you can clearly see there's a treatment benefit of being on background mycophenolate therapy. And this could certainly be because it could help improve lung function, which is what we saw in scleroderma lung study 2, but also because we know it works on other dimensions of the disease, such as improving their skin thickness, improving arthritis, and also improving how they feel and function based on patient-reported outcomes. But in thinking about the combination of the therapies, it's a little bit tricky because while that 6 months was an entry criteria for the study, most of the patients actually had been on a stable dose for a year before they entered. And then we actually don't have any information on whether they continued it during the trial. Presumably they did because they had been on a stable dose, but it's possible that they could have come off the mycophenolate. I think there's a study going on right now that could better help us answer the question whether the combination of immune suppression plus an antifibrotic is better than just immune suppression alone. And this is the scleroderma lung study 3. And this is comparing mycophenolate plus pirfenidone to mycophenolate alone. And in this study, patients are all on background mycophenolate. So it's going to be a little bit easier to interpret the results. I hope I answered that okay.
And I think there was a follow-up to her question regarding the average duration of mycophenolate therapy prior to enrollment in the census study. I don't recall what the figure was.
Yeah, so the entry criteria was they had to be on it for at least 6 months, but when they looked back at the dates of when patients started it, most of them had actually been on therapy for at least a year.
Okay, and we have another question from Dr. Kim Bloom. This is regarding checkpoint inhibitor therapy for patients with CTD-ILD. And what has been your experience with patients like that, and how do you manage them?
So I don't think we have any large randomized controlled trials with these therapies yet, but that may be coming in the future. So it's not something that I typically use in my patients with CTD-ILD, but again, it could be something that we look at moving forward, especially because of the role these may play in managing extrapulmonary manifestations of the CTD.
Great. So next question is for Dr. Levine. So this is from Dr. Sandeep Sahai regarding the INCREASE study. So the study also showed improvement in forced vital capacity that was independent of walk distance. And he was wondering what you've thought of this result in this population.
Oh, thanks, Sandeep, and hello. No, that was a very interesting part of the study, and it was unexpected. However, and again, as you discussed, that their walk test was also improved. And I think everyone who was on the study, I think really in our cohort of patients really did feel better. Not only was their walk better, they also felt better. I think the two options or the two possibilities are, number one, because they were feeling better, did they do better on their PFTs? And number two, did the drug somehow have an effect on their vital capacity? And I think there's more to come on that. But I think the question is, when these patients don't feel as well, and they do feel improved after the therapy? Are they improving because they're just in general doing better? So I think it's a good question, and I think we'll need to learn more about that specific group of patients.
And Joe, would you share with us your experience with checkpoint inhibitors in patients with ILD? How does that impact their disease? I think that's ILD is obviously a very broad category, right? So, but these patients clearly have a higher risk for developing lung malignancy. And how do you think that should be, or how do you think we should consider the use of these checkpoint inhibitors in these patients? Because has been associated with pneumonitis, and I think that's becoming, kind of a well-described phenomenon.
Yeah, so this is, I think, a shared decision-making with the patient, but there is one publication in ERJ that I can recall from a couple of years back where they happened to look at patients who had reactions and those that were on had connective tissue, and they had some pretty severe reactions occur in those individuals. So I don't think it's a very perfectly designed study because it was a retrospective look, but enough to I think have the discussion with the patient for shared decision making, because they saw the occurrence of this, and oftentimes it was severe, 3, 4, or death as far as the severity. So, but I think the answer to the question is still not known.
Yeah, I would just add on to that. We also I get a lot of referrals for patients who are put on these for their cancers, and then oftentimes they have severe flares of arthritis and, again, other extra pulmonary things going on. So that might also impact the decision about whether to have a patient with this on it.
And so I have a question for Elizabeth. So you guys obviously have a large and very active lung transplant program. And so when you see patients who are referred for transplant who are, quote, too early, what has been your kind of approach to managing these patients with significant connective tissue disease?
I mean, I think in all of the patients, we really try to be very aggressive about treating their ILD with therapies. Even when they come to us at a point where they may be needing a lung transplant in the next year, we still try to offer them treatment, because many times, especially diseases such as myositis, immune suppression can have kind of dramatic effects on patients if it's given at the right time. So I think that we typically are very aggressive with treating them in some of the ways that I discussed there in the talk, regardless of where they are in the transplant process.
And then on the post-transplant side, do you try to remain involved in those patients? Like, for example, we recently transplanted a gentleman with dermatomyositis, and he's doing well from a lung standpoint, but within a very short period of time, he was starting to have recurrent skin manifestations, despite being on more immunosuppression after transplant. So how have you been able to handle those patients?
Yeah, absolutely. I think it's really important that just because they have a transplant doesn't mean they need to stop their rheumatology care and also the multidisciplinary care that we provide. So oftentimes we make decisions about their post-transplant immune suppression based on not only just the organ that's been transplanted, whether it's a lung or a kidney, but also what else is going on for the patient. And we've had discussions with the transplant pulmonologist where we've switched them from mycophenolate to other things with some evidence for preventing rejection, just to address their other manifestations. So switching to something like rituximab.
And then I have a question for Dr. Levine. So, the frustrating part, as you mentioned as one of your last slides, is, even if people are referred early, sometimes we missed a boat. We get them even listed, or, it's just there can be this sudden transition from stably managed pulmonary hypertension to complete decompensation, very rapid. That occurs very rapidly. What would you recommend as far as kind of more intensive surveillance in these patients, and really kind of trying to make sure they don't miss that window of opportunity?
No, that is a really that's a great question, and comes up all the time in our listing meeting. Is that what we've begun to do, and we kind of took this from our liver colleagues, is that in our portal pulmonary hypertension patients, we've been checking their echoes quite frequently, even while they're on the list. For our ILD patients who may or may not already have PH, we've seen if you watch their progression over the time that they've been in your care, whether it just be following them prior to transplant or while they're on their list, you can see their echoes serially get worse, and it's very interesting. And so we're following their echoes a little bit more carefully. The question is, what are we going to do about it? If they're on the list, they're going to get transplanted, but you also know perioperatively that they may have a little more problem if their right ventricle works well. It just may be a little dilated, but if you wait a few months, you know as well as anyone that that can change rapidly. And making sure you do know that going into transplant, so you know what type of perioperative care he or she may need is important. So we're following more serial and more closely spaced serial echoes on these patients.
And we have another question for Dr. Levine from my partner, Ahmad Goodarzi. So he's asking about the use of IV vasodilators in PH-ILD in patients who are already listed. What is your approach to deploying that sort of therapy? And do you think there's good rationale for that?
Well, we have done that, and I think most transplant centers have a PH center as well. So working along with the PH center, and I think as Dr. Volkman talked about, a good multidisciplinary team working both with the PH and transplant team to discuss this together. And yes, we've done this on specific patients, but again, in a controlled situation. And so when these patients are seen, I think even in Dr. Nathan's kind of flow chart, when these patients do come up with or without transplant, having them referred to a center where the PH clinicians will have a little bit better handle is probably what needs to happen. And obviously, as that patient moves forward to transplant, this will be still an important option for us under the right care.
Sure, absolutely. Good. Seems to be an echo here. Okay, well, I think that takes us to the end of our session. Are there any other questions from the audience? I think this has been a really great series of talks, and that just really kind of summarizes the state of the art, and also illustrates how it encompasses multiple fields and disciplines, and how I think we need to think more broadly about interstitial lung diseases in general, right? So transplant is a tool in our bag, but it's not the appropriate tool for everyone, unfortunately. And sometimes recommending transplant too early may actually be doing the patient a disservice. And so certainly, I think our approach should be, just as a community, to really think about kind of all the other things that are available to us that can help, the patient, instead of just focusing on transplanting. One kind of closing question for me is that, I think COVID-19's really kind of brought to the forefront, and kind of how we can maybe do research, clinical research a little differently, and maybe on a different timeline, and, kind of being able to really move quickly and assimilate data and kind of figure out what works and what doesn't. So, I'm going to ask all my panelists, how do you think we can kind of apply these lessons to like ILD for the future? How do we do that? How do we kind of figure out what therapies work? And how do we do it not on the old timeline, but maybe on an accelerated timeline, like what COVID's taught us that we've been able to do?
I think for me, really all of us have these patients, but as we've seen with even the vaccine, there's unfortunately so many COVID patients that the vaccine, one nice thing is that the vaccine will be, out earlier than expected. And I think numbers are important, and being able to come together as a community, both ILD and transplant centers, to look at these patients as a group. And I think that is probably one of my thoughts taken away from COVID, because I think what we need is not single center studies, but groups together after maybe working on it through good collaboration and standardizing of maybe some definitions and of what we want to use, looking at these therapies together.
Yeah, I would echo that. I mean, I think that we use a lot of multidisciplinary approaches when it comes to the clinical care of patients, but often when it comes to research, we're often working kind of alone. We're sitting at our computers writing grants alone and then getting funding. But I think what COVID has taught us is that we really work together with other specialists to do this research. We can probably get it done more quickly and effectively, and kind of share the fruits of our labor versus just one person, applying for a specific grant. The other thing I'll mention in terms of COVID, because this wasn't in my talk, but I recently published a small case series of our patients with CTD-ILD who got COVID. And very interestingly, all of the ones that had been on background mycophenolate fared quite well. And we even had one patient who's probably weeks away from getting a lung transplant and didn't even need to be hospitalized. And then our one patient with CTD-ILD who had the most mild ILD you could imagine had horrible COVID pneumonia. We treated her with tocilizumab and she did very well. But I think that there's going to be a lot to learn too about potentially the role of background immunomodulatory therapy in maybe preventing these severe COVID complications, possibly.
I think some of the things we've seen that countries have been able to do, such as the United Kingdom, were to have multiple studies against one placebo group. And so they're able to test 4 or 5 different agents against a single placebo group. And so then accelerate things. It's a very competitive environment, as you know, right now for COVID, enrollment of patients into trials. There's so many trials going on right now. And so this is one way that the United Kingdom has solved that competition between trials. It's the same thing with these interstitial lung diseases. There's a half a dozen trials out there right now, all competing. Is this ever going to happen when we have an industry incentive? I'm not sure. Of course, we're always looking for a biomarker that's going to tell us, within a month of going on drug, is there any poetry in the drug? But although there's been some work done in this area, we certainly don't have anything at this point that would accelerate it to the point where the FDA would say, yes, this is something that we're going to accept for approval.
All right, fantastic. Well, thank you everybody for a great session, and truly appreciate your sharing your expertise with us and joining us. I'm just sorry we couldn't be meeting in person for dinner. But we'll give you a rain check.
Thanks, Howard. It was a great session. All you guys, great talk.
Thank you so much.
All right, take care. Thank you very much. You good?